live.
So I'm going to refresh.
The audio of Henry is working now?
Yes, it's fine.
Hi, Henry.
How you doing?
So we are live, boys.
Wonderful. Wonderful. What a treat. What a treat to be able to bring this type of quality and education to the world through this medium in such a trying and turbulent times in the world. To have friends that we can contact, call on, and provide their experience, their expertise with us, with our audience, and with the world is really special. I'd like to thank Mark Bishara. Mark was the engine of getting this together. It was an idea that came about very quickly. In less than a week, we were able to get all of this done. And there's nothing like being able to accomplish something and be able to share it with the world, with dear friends. And we have Mark Bishara on. We have my brother Henry Salama on from Philadelphia. And the first speaker, this symposium that we wanted to do is meant to be very short presentations, very concise presentations aimed at providing specific messages to the audience. And the first speaker comes to us from Lebanon. He's been a friend of mine for almost 20 years. He's a specialist, as is all the other speakers. Every speaker that we'll have today is a specialist in perio, prosthetics, oral maxillofacial surgery. So we really, really are appreciative to all of you. Alan did his perio studies here in the United States at University of Alabama, Birmingham, one of the better perio programs in the country. I got to know him when he was still in his program, and I saw his potential, and it's a pleasure to see him develop into such a great clinician and a great educator. So, Alan Romanos, please show everybody why we're so impressed with you. We're looking forward to your presentation.
Thank you, Maurice, for this kind introduction. Before we get started, I want to really thank Mark for putting this all together. It's a great honor to be on this virtual podium with you guys and with such a prestigious group of speakers from all over the world. Before we started, I just want to tell you that the topic that I picked today is all about soft tissue. And most of the things I learned in soft tissue and aesthetics was because of you, Maurice and Henry. You guys, you were influencers to me when I was a student 20 years ago when I did my training. And if you remember, the thesis I chose at the time about papilla was because of you too. So I'm really grateful for all the things that I learned from you, and I'm still learning. And it's a great honor to be on this podium with you guys. Today, I will share with you some of the work that we do on soft tissue grafting techniques and immediate implant placement, and share with you our philosophy of treatment. We'll go through the immediate implant placement, the 10 factors, the 10 steps that we go on a daily basis today. We'll share with you some of the study that we finished, the 3 years follow-up, and it should be published this year. A nice project. I had a hard time to finish it because I was too busy, but it's really ended up being a good project. We'll talk about the advantages and disadvantages of each of these soft tissue grafting techniques, and we'll show you some of the future research that we're planning on doing at this point. So, you know, the extraction socket or the aesthetic implant still today a challenge. And patients' expectations, especially when you're in private practice, are completely different than when you're at school. They have very high expectations. And we as the clinicians, we have so many risk factors to deal with. And, you know, we know today the history of tooth loss and this theory of the bundle bone loss, and this how will affect your final aesthetic outcome. And the impact that this can have on the papilla reduction, or when you do everything you can, and at the end of the day, you still have this concavity, which will affect your final prosthetic outcome, or, you know, lack of keratinized tissue, which again, will be sensitive tissue to clean, and patient complain from this. Or you wait a little bit and you start seeing this mid-facial recession happening, or even worse, you wait and over time, you can start to see the implant shining through the tissue. All these are really nightmare for dentists, especially for people who are working in the aesthetic zone. And if we look at this at the studies, we know today, once you take the tooth out, you will have some bone loss in both dimensions, vertically and horizontally. And socket preservation or alveolar ridge preservation techniques will not stop it. It will limit it, but it will not stop it. Placing the implant immediately, again, it will not stop it. Placing the implant with bone graft, you still have some loss. And the recent technique that you guys, Maurice and Henry, you developed over the last 10 years, the socket sheath, it's a great technique, but it's not a technique that it's indicated on every single patient, especially for people who have root fractures or vertical root fracture. So the question happens, when you have patients like this, patients are depressed, they lost their front teeth, and they have a high smile line. And when you have patients like this, today's challenge is not just to replace the tooth, but to do it fast and right and get these patients to function. And this back in 2009, this is what was at the time the standard technique with these patients. So this root fracture, we took the tooth out, we placed the implant in the ideal 3D positioning, we graft the gap, and we placed the zirconium abutment. And then when you look over, we delivered the final crown after 3 months. And when you watch this case over time, this is a CBCT after 5 years, you can still see this buccal bone supporting my implant, which is good on the X-ray. But when you look on the final aesthetic picture after 5 years, and of course this patient did not complain, but because we're a bit meticulous, you can see some retraction of the tissue, and there's about 0.5 millimeter of recession, even though I tried to do everything to preserve the tissue and the aesthetic. And when you look at this recession, the patient did not complain, but I complained. And when you look after 10 years, you can see this concavity on the buccal of this implant, which will affect, if you look at this at the tooth, this patient complained sometimes during the day or at night. She see the color of the crown differently depending on what time of the day, and you can see the tissue around the central incisor. It looks different than the adjacent tissue. So even when you do everything right, you think you did everything right. You place your implant in an ideal 3D positioning. You graft the combination of autogenous and xenograft, screw retained temporary. Look at the CVCT, wonderful implant placement. Soft tissue thickness is wonderful, but still at the end of the day, you still have some deficiency. So the question becomes, this technique, the trimodal approach, even when you pick your type 1 socket and you do everything right, you still have some limitation. You have to expect 0.5 millimeter of recession at 1 year, some changes in the vertical and horizontal changes, and in extreme cases, 20% of these cases were failed aesthetically, even when you pick the right case to do this technique. So the question becomes, what if we add a connective tissue graft to counteract these changes? And this is the 10 steps that we follow in our clinic. We always carefully assess our patient by measuring the soft tissue, pictures, photos. We scan today all the patients that they comes in. We have digital scan. We take CBCT on every single patient. And of course, if you're planning to do immediate implant placement, you want the CBCT to see if you can place your implant immediately. We use all the minimally invasive technique for extractions, from easy extract to physical extractions, to piezo surgery. So you do everything flapless in order to preserve the blood supply. We check the buccal bone if there's any fenestration or dehiscence. We prepare for an ideal 3D implant positioning. We choose our implant based on our socket diameter. And if we have a good primary stability, this is something that we do routinely. We do immediate implant non-occlusal loading. The one thing different that we start doing for the last 5 years now is we harvest either connective tissue graft or we use acellular dermis matrix. And we try to convert this biotype to thicken the tissue. And the question is, it started, if you look at the early study back in 2011, Uli Grunder mentioned in this study, when you add a connective tissue graft, you always gain some contour, and it gives you more contour than the group than if you don't do any connective tissue graft. So in one group, you lose one. In the group that you use connective tissue graft, you gain 0.5 millimeter. So we start to do this back in 2012 and 13, and we start to work on this. And you look at over 40 articles that support the use of the soft tissue in terms of having extra tissue on the buccal side, so you don't run the risk of having any recession when you do immediate implant placement. So this is the philosophy of treatment. But the question becomes now, if you have to use every single patient a connective tissue graft, what are the disadvantages of this connective tissue graft? Well, we know that, all of us, we have at least once a year patient who get necrosis from the palate. Other patient, they get bleeding. It happens to me till today. Once a year, I have to go back to the clinic at night to stop the bleeding. Or some, in extreme cases, patient get ecchymosis or swelling, or infection, which is rare but still happen, or pain, prolonged pain, 3, 4, 5 days of pain from the donor side, or in some cases where patient has some sensitivity changes in the donor side. So all these are complications related to the connective tissue graft. And it happened that we published this article back in 2017 on treating multiple recession. We had in this study 18 patients that we did the full mouth recession. And what we looked at the time at the number of pills that these patients took in terms of pain. And what we found, there's advantages to the donated tissue. Well, first, it decreased the patient's fear. 2, it reduced the surgical time at least by 20 to 30 minutes. And if you're doing full mouth recession, here we're talking about 40 minutes. And then in some cases, even if you're planning to take the connective tissue graft, even if your plan was to go to the roof of the mouth, there's nothing. And I don't know if it's in Lebanon this way or in Atlanta, but here in Lebanon, Maurice, we have 90% of the patients, they have no palate. I don't know what they do with the palate, but really they have a thin palate. I remember this patient because we took a free gingival graft. It took her 2 months of pain because we exposed the bone for this thing to heal. So what do you do with these cases? And of course, for the smokers in the study that we did, in Lebanon and Cairo, 90% of the population are smokers. So the best is to take really if you take the connective tissue graft from the palate, these patients might have a sloughing on the palate. It is the treatment of choice for young population because I hear this every day when you offer connective tissue graft to a young kid or a girl, they tell you, well, I don't want you to play with my palate. Can you do something else? And so in this study that we did for full mouth recession, the number of pills that these patients took were 2 tablets of painkiller for a full mouth recession. So we took this, what we know, and we tried to apply this in the study that we did. So we took 20 patients, 24 implants that we placed in the aesthetic zone. One group, 12 patients, we placed 12 implants with a connective tissue graft and 12 patients with Alloderm. And we did, of course, switching platform implant, 3D implant positioning. We graphed the gap with the xenograft and autogenous. And we documented these cases for 3 years now. So we have a CBCT initial, CBCT at 1 year, CBCT at 3 years. And we delivered the same day, most of these cases, the temporary 3 months final prosthesis. And so one group, we harvested the free gingival graft, converted into connective tissue graft, so the Zucchelli type of technique. And the other side, or the second group, the test group, we took an Alloderm and one foam. And just to share with you a quick video how we do it. So this patient had a fractured root, so we use the periotomes, atraumatic extraction. And again, we go through the 10 steps. We scanned this before. We place the implant in an ideal 3D positioning. And we use the patient's own tooth as a template. Here we place the Alloderm or the connective tissue graft, depending on the group, marionette type suture just as a tunnel. We graft the gap, always combination of autogenous and xenograft. And so this is the treatment that we did on all these 24 patients. And so this is another test, another patient that she was about to lose the 2 laterals, 12 and 22, number 7 and number 10. And so again, CBCT, initial exam, initial therapy. Then we take this patient through the surgery. We place the implant in an ideal 3D positioning. Then we remove the remaining roots. So we place the implant first, and then we use combination autogenous and xenograft to graft the gap, free gingival graft on one side, Alloderm on the other side. So this group you can see the implant, the combination of the bone graft, and then one suture just to fixate this connective tissue graft on the buccal aspect without any flap. On the other side, again, same 3D implant positioning, and then we place the implant, graft the gap, and then place the alloderm. Temporary, same day, 1 week, 2 weeks, 12 weeks, we deliver the final crown, and this is 3 years. 3 years, we take the CBCT. So here we have this side we have the connective tissue graft. And as you can see on the connective tissue graft, after 3 years, this type of graft continued to grow, while the group of the alloderm, it didn't lose some. I mean, there is a bit of volume loss after 5 years. And this is a 5 years follow-up on this case, which we can see that the group of connective tissue graft gained more volume. So this is the study. This is what we did to almost all of our patients. So the question is, what were the results and what we're doing today? So this patient, Dorina, she's 69. She's a good example to what we do today. She did not have too much of interest in aesthetic, but she was kind enough to donate her teeth, her extraction, her implant for research. So we decided to do on Dorina, first she lost number 22 or number 10. So we decided to take the tooth out, place the implant in an ideal 3D positioning, connective tissue graft, same as we described in this protocol, and then graft the gap with the combination autogenous and xenograft. Deliver the temporary, screw retain. This is 1 week healing. The connective tissue we're taking from the tuberosity. And this is 3 months of healing. And you can see we were able to maintain the contour on the lateral with the connective tissue graft. 6 months, and you can see again the contour still maintained very nicely. She came back after 2 years. She fractured the canine, number 23 or number 11. And, so I told her, listen, we can just do a trimodal approach. No need to do any graft, just to compare the lateral to the canine to see what are the changes can happen. And she was kind enough to just accept the treatment plan. So we decided to take the tooth out, place the implant ideally in a 3-dimension, parallel pin. And again, same technique, just we did not add any soft tissue graft. So now we have the lateral with the connective tissue graft, the canine just trimodal approach, extraction, implant, temporary. And then she left, and then I came back after 1 year. She fractured now the central incisor. So now we have 3 implants next to each other. And I told her, Dorina, listen, you've been kind enough. Now I have on this lateral, I have the connective tissue graft. On the canine, which I didn't do anything, and you can see some recession, and you can see the soft tissue contour that she lost because we did not do any soft tissue graft. And now we lost the central. And I said, listen, we can try to do, instead of doing connective, we can try to do a double fold alloderm. And she was like, fine, you guys can do whatever you want. This is for research. This is for sharing science. And this is what we did. So we took the tooth out. Again, same technique, same philosophy. Place the implant in an ideal 3D positioning. Same, use the patient's own crown as a temporary. And then we double fold now the alloderm, because in the study that we did, the results showed that we lost some. We lost about 0.5 millimeter. So I thought, if I double folded, what if we can probably maintain the same volume? So we double fold this alloderm and we placed it the same as a tunnel to support my buccal bone. So we placed this, and again, same combination, bone graft, autogenous and xenograft, and the alloderm to support my soft tissue. We sutured this back up, let it heal for 3 months with her own crown, bring her back after 3 months, and look at the nice volume of the soft tissue. And again, this is the double fold alloderm. And then after 3 months, we took her to the final crown. So now on Dorina, we have a 4-year follow-up on the lateral. We have a 2-year follow-up on the canine and a 1-year follow-up on the double fold alloderm. And what you can see from this, it's nice because we have 3 different techniques on her mouth. And what you can see is that in Dorina's case, where we did the connective tissue graft, it's still growing till today, and I'll show you a profile picture. The group where we did the double fold alloderm, it maintained comparing to the adjacent one, and the group that we didn't do anything, there is some recession, and there is some gingival contour or gingival concavity. So, and you look at Dorina, now she's bothered by the extra tissue coming from the lateral. Of course, we didn't do anything, but we can always plasty this. So this will summarize our philosophy of treatment today on how things. So this is a study that they used the same thing, but they used a xenogenic collagen matrix in a double fold. And they did not try it in the aesthetic zone. They just tried it everywhere, in the maxilla and the mandible, anterior and posterior. And what they found, when you double folded, they end up gaining 1 millimeter of gingival thickness, which will counteract what you lose. So this 1 millimeter that you lose from the extraction, you will gain it from this xenograft. And of course, the other advantages that the shorter surgical time, the lower post-operative pain, and the number of painkillers that this patient took. So to conclude this, the question is, what would you choose in your patient, in your daily practice? Would you put a connective tissue graft? Would you use alloderm one fold or double fold? Well, from the study that we did, which will be published hopefully this year, we have 100 success rate in both groups and the 24 implant. The PES index were good to optimal. Patients were happy, we were happy. Scores were 12 to 14 in both groups. Of course, the alloderm group were better accepted by patients. So when you're talking to patient and you're proposing whether they want a connective tissue graft or alloderm, of course, 90% they will go to the donated tissue. And in our study, the number of painkillers were double for the group of connective tissue graft. So on average, the alloderm group, they took 2 painkillers, the group of connective tissue for at least 4 to 6 painkillers tablets. And the other finding is that, and this is, in some cases, like in this case, you can see this group of free ginger or the connective tissue graft after 5 years, it's keep on growing. Of course, in the group of alloderm, we lost almost 0.5 millimeter. So we have a gain of volume of contour with the connective tissue graft. And you can see, of course, this is 1 or 2 patients we had to go back and plasty after the study because these patients were bothered by the amount of volume of the soft tissue. The other finding that we found is with the connective tissue graft, you have extra tissue. So forget the buccal recession, we have extra tissue. We always have 0.5 millimeter or so. So these patients, you end up with more tissue, which you can remodel with the temporary, or you can do a gingivoplasty at the end of the treatment if you wish. But we always had extra tissue with the connective tissue. So to finish this off, my conclusion would be, all the decisions should be taken, of course, before tooth extraction. And I learned this from you guys. And of course, we have to carefully select our patients for the immediate implant placement by doing the 10 things that I went through quickly. We have to know what we're doing. If you have a high profile patient today or high risk patient, I tend to use the connective tissue graft just because I'm very comfortable with this technique. If I have a very anxious patient, very stressful patient, I use the double fold alloderm because I'm pleased with the result that I'm getting. And if you have an easygoing patient who's not interested in aesthetic, just, what the heck, just use the trimodal approach. So this is what we do today in our philosophy. With this, I want to finish by a small quote. We know that life is a cycle, and every after difficulty, there's always an ease and a new beginning. I hope this pandemic of Corona will end soon so we can see each other back, guys. I miss you all, and I'm looking forward for the question session. I was on time, Maurice, right?
Perfect. Unmute your audio, right? Yeah.
Yes, my audio's on. I can hear you.
Right, you were right to the point. I couldn't have asked you to do a better job. I think all of us got the message. It was really, my question that I had, I have several. First of all, I think that in cases where, obviously for us, we've had the momentum is swinging towards looking very critically at our post-extraction cases, because over many years, even with using the dual zone techniques and some of these other techniques, found some resorption remodeling that occurs even many years later, several years, you'll see further changes. So I compliment you on the fact that using bone graft and using tissue to compensate for the natural resorption extraction site is the way to go. My question would have been, number one, you make it look so easy. Tunneling on the labial in very thin tissue and being able to place, especially acellular dermal materials into that tunnel. Sometimes because you strip off periosteum, you sometimes will get some difficulties in that thin tissue being able to maintain vitality to that acellular graft. So I want to know if you can speak a little bit about your technique, your microsurgical technique, and when you would and when you would not choose acellular tissue. Is there a tissue thickness requirement?
Great question. You know, honestly, before the study, when I had a very thin tissue, I would lean more toward using connective tissue graft instead of alloder. But there's these two cases that I did through the study, and they were both really thin tissue, and the randomization was to use alloder. So it was really thin. And of course, in the 10 steps that in our immediate implant placement protocol, the number 10 is change habits. What I mean by change habits, for the last few years, we've been using microsurgical instruments, and we both work with Devamed. They help us to come up with these smaller little instruments. I help to design for us new small instruments in order to tunnel the alloderm. And we use always microscopes and loops and lights, like extra lights. So doing these three changes, microsurgical instruments, loops 5-6 times bigger, and extra light, these are the things that help me with my surgical technique. The second modification that sometimes we do is we do a mini frenectomy type incision to help tunneling laterally. So if you cannot do it from the top part, we can always make small punches like the pine hole thing, just to help dissecting this tissue. But you're right, this is something that it is a concern theoretically, but clinically we did not have one single complication. And we've done in this case 14 cases back to back, and today outside the study we almost did 50 cases.
Fantastic. Second question for me would be the selection of autogenous connective tissue. The tuberosity has a tendency of latent proliferation. It continues to expand, it continues to grow over time, and it changes color. Would you consider changing the type of autogenous tissue you harvest for these cases rather than going to the tuberosity?
You're right. There's the three disadvantages of this technique that I found throughout my last few years. One of them is the color. You're right. It's whitish type of color. True, the continuous growth. And the number three, not too many people talk about this. If you don't remove the whole epithelium, in some cases we see you push on the tissue and there's something white. I called it the noodle technique. You have sort of a noodle coming out through this sulcus. So if this is really, we've seen this more and more often. Today, I like the connective tissue graft, but I chose in this protocol to use the free gingival graft just because we know from the Zucchelli articles on recession, because we needed more volume either to hide the titanium implant or to have more extra tissue. But I think for what we do, if we're doing just immediate implant placement, connective tissue graft will just do it too.
Wonderful.
So we got one more question from Howie in South Africa, and he's asking if the acellular dermal matrix works quite well, why not make this your first choice as a technique instead of CTG?
Honestly, today I'm doing more and more the double fold. So I'm using it as a double fold because it shows that this will counteract the changes that happen after extraction. I try to combine, if I have an extraction of wisdom tooth, if I have something to work on the maxilla, I try to combine the connective tissue graft at the time with my implants, if it's possible. If not, yes, I would always go to alloderm today. Yes, he's right.
Okay, wonderful.
I have a quick question on that. If you don't immediately provisionalize, how do you seal your grafted site over the implant?
If I don't, all the cases we do immediate provisionalization, but now what we're doing today, Henry, we're doing it a bit differently because we have in our practice, we have a lab, in-house lab, and we have almost everything digital. So today, the way I'm doing it, it's different than I used to do in the past. We scanned beforehand, we scanned after the surgery, and then I place a custom-made healing abutment till the next day. And my lab technician deliver me the final zirconium crown. So I place as a temporary a zirconium crown for 3 months, which I'll throw it away and make him a new one. Because we have a lot of patients, and I can tell you some of these patients, they didn't want to change the temporary crown because they were so happy with the shape and the color.
Okay.
There was a question about sutures. Is there a particular suture you like to utilize?
I usually use a 6-0 Vicryl, just one suture to stabilize the graft to the flap, just a one marionette type suture. So flap, connective, flap, one suture. That's it.
Very nice.
Okay.
And I'd like to thank you so much for spending your time with us. I know there's a curfew in Lebanon that you need to get back to your family. We really thank you so much and want to let you know that it's so much appreciated. Stay safe, stay connected to us, and we hope that we will see you again soon. Keep up the great work you're doing at the university. You're an educator, a teacher, a faculty member, a friend, and we wish you the best. Thanks so much.
Thank you. It's a great pleasure. I'm honored. Thank you, guys.
So we'll take a 1 minute pause till we get the next speaker in line. So stay tuned, guys. Okay. So you can, thanks so much. That was great. So we got to get Richard in here next. You watching it on your phone, Mo?
Yeah.
Yeah. So
basically, the banner came up.
Yeah, I just right now no, it's on mute, so it's just the banner.
Okay.
Yeah, I think.
Very good job, Mark. Yeah. I know Dean. It says Dean's iPhone.
I know he logged in with his iPhone in the middle of it, so I clicked OK, so it doesn't have that orange pop-up blocking the guy's presentation. I don't know why he came on now, to be honest, but it's okay.
Will Richard be able to pop into that space?
Yeah, so I'm gonna just get him off here. Put in waiting room. Okay. Richard, admit. He's next. This is like the green room for the NBA draft.
That was quite good. That went very, very nicely. I enjoyed this presentation.
Yeah, it was good.
Listen, everyone can hear us, so don't say anything bad about Richard. Listen, are we back on?
Give me 1 sec here.
Richard, get closer to the screen.
Richard, get a little closer, man. You're too good looking to be that far away.
There you go.
Yes, God.
Yeah. So everybody can hear us, just so you know.
All right.
Okay.
Well, then this is perfect. I can't imagine utilizing technology and having such an ability to have your friends on with you, all sharing this at the same time. It's amazing. And it's when we first considered what we wanted to do with DentalXP, it was 2006. And everybody, sometimes I get people that ask me all the time, Richard and Mark, and, they ask us, how did it all begin? And it actually began in a swimming pool where I was sitting in the swimming pool with my children that were very small sizes at the time. And my brother, Eddie, who at the time had nothing to do with dentistry or DentalXP, said to me, rather than continue to leave your kids all the time, and isn't there a better way to stay connected with dentists around the world? Why can't you just do some of this and provide it online through the internet? And I remember sitting with him and thinking, wow, that's a great idea. And when DentalXP really came out with a beta site in 2008, and then finally 2009 launched, so now it's been 11 years. When I see all these webinars going on and all these live streams all around the world, I realized that we really did have, a big impact on dental education around the world. And right around that same time, I met this young man, Richard Martin, at a Synergy event in Orlando. And Richard's an oral maxillofacial surgeon from Dallas, Texas, but he keeps it a secret, originally from Jamaica. He comes from a family of medical surgeons. This guy has all of the skills of a cardiothoracic surgeon in his gene pool, in his DNA. He's I used to say hybrid surgeon, but he's not even just a hybrid surgeon. He's a hybrid of everything. He knows digital, he knows surgery, he knows prosthetics. He really is a stellar clinician, a dear friend, fantastic educator. He joins me on many of our hands-on mastership courses, bone, but sinuses, always his favorite hands-on course. And we can't wait to have you with us, Richard. Thanks for taking the time. The world is waiting. The screen is yours.
So you're
Thank you.
Live and ready to go here.
All right. Thank you so much, Maurice, and quite an introduction. It's actually about 15 years that we've known each other, as well as you, Henry. Mark, for you and I, it's been about six or 7 years, and I'd like to thank you, gentlemen, for inviting me to do this presentation. And without further ado, because I can be long-winded, so I'm going to use every minute, every second of my time. So my presentation today is digital full arch rehabilitation utilizing the Ritter system and the pick impression technique. As Maurice said, originally from Jamaica, but practice in Dallas, Texas. So I'm going to do this in kind of a case report format, something you normally don't see in a presentation, but quite an interesting case. It's a 60-year-old African-American male that was introduced to my practice back in 2004, placed the implant on number 13, restored, no problem. Diagnosed in 2006 at age 46 with extranodal marginal lymphoma, which is one of the non-Hodgkin's variants. Chemotherapy, unfortunately recurrence in 10 and 12, and finally underwent stem cell transplant, and he's been fairly stable since that time. However, I've had to pretty much extract all his teeth over the last 8 years and ended up in a maxillary denture and mandibular transitional. So here's Anthony, and I have permission to show face and whatever I want to do with him. So I'm going to kind of show you what he encountered. So we're going to go ahead a little bit.
What's been going on with these teeth over the last 15 years that I've been treating you? Well, they've been falling out, breaking off. They're taking good care of me. Got this bottom plate.
Just listen closely.
Almost like an elephant puts a rock in his mouth so he can chew. That's sort of what it's like having this bottom plate. It just hurts, cuts into my gums. Top plate, not.
So again, Anthony became a friend of mine, and I had to come up with a solution for him to be able to eat, because as you know, in these immunocompromised patients, any opening in the oral cavity and exposure of the bone can, really lead to some osteomyelitic changes, which we didn't want in him. So what I decided was that in this case, we would go ahead and digitally plan this case and try to see if we can do both the maxilla and the mandible in a staged fashion. So you can see here we have a little bit of a overbite, overjet issue here that we'll correct. Radiographically, however, if you were just to look at this and not know Anthony's history, you would say the bone looks, quite healthy. You can see my most recent extraction site here, and then the vascular clips from his surgery. So again, dealing with a very compromised patient. So back in around 2015, I decided that, it's time for me to start doing these digital full arch cases. I've been using digital technology, intraoral scanning, for almost 6 or 7 years prior under the tutelage of Maurice, Dean Vafiatas on the site here, Agnini Brothers. So, it wasn't anything new to me, but I'd always done the old traditional way of grinding, cutting holes in dentures. And I just got tired of doing that. One of the things I always like to say is we oral surgeons have short attention spans. And, sitting chairside and converting or doing these cases just really wasn't a thing that I like to do. However, when I was taught how to do it from the digital workflow, it really became a no-brainer. So here you see we have Anthony, and we're going to use the digital smile design concept by Coachman, as well as the 3-shape overlay. And we're going to do digital wax-ups of his case. So we're going to overlay the scans, the CBCTs, the intraoral scans, and we're going to go ahead and implant. So here's a maxilla, a simulation. We're going to correct tooth shape, tooth form, get our little buccal corridors a little wider. We're going to do a mandibular work, which we normally don't see. But again, with technology, we can simulate that. We can do that. We can increase his vertical a bit there. And surgically, our plan here, utilizing now, I think we're up to about 3 softwares. So pay attention to that, of how many softwares we're able to utilize due to open architecture. So we have the overlay here of the mandibular denture, implant position, vital structures here. And I like to place 5 implants, and especially in his case, being that he was immunocompromised, I wanted to build in a little backup. There's a little statement that we like to use, and it says superhero always had a backup. So Batman always had Robin, and Clark Kent or Superman always had Lois Lane. So one of the beautiful things that I like about digital technology is we get a blueprint. For me, this is the game changer here. I have my implant manufacturer, I have my lengths, my diameters, and I also have my multi-units here. For me, the multi-unit is the key here because I know my angle. So in my posteriors, I've got 30 degrees with 2 millimeter cuff heights. In the anterior, 0. I also have my part numbers so I can order and keep my inventory control down. For those of you that have been doing these cases for a while, you remember in the old days, you had 5 or 6 of each parts. Now, if you add that all up, I mean, the profitability on these cases pretty much can become 0. So we're going to go ahead and use the Ritter Fully Guided Kit designed by Maurice Salam and some of the other members in this group. But what's interesting here is we have the ability to guide the narrow line implants, which you don't see. So here is our little seating jig, very important, probably the most important part of the whole case, because this is what we put our frame in place with, and everything else attaches to that. Our little seating jig here for our multi-units that you'll see in a bit. And here's all our parts and pieces, all our printed metal guides that we're going to swap in and out throughout the procedure. So intraorally, after we've done our reflection, we've put in our frame. This is our frame here, and you can see these are Swiss locks. Everything connects in here. But this is a sleeveless system. Sleeveless as well as keyless. Again, another feature that you normally don't see. One of the things about using keys is keys have the tendency to get stuck in these guides at times. You can damage the drill, you can damage the guide, and pretty much you can blow out the bone. So again, in this case, everything I did was critical in relation to Anthony's medical history. I didn't have a lot of options here. I don't know if the only backup I had was really the implant placement and adding the numbers. So here you can see we're placing or prepping the sites, and the posterior sites, you come in at an angle. And so one of the things that I developed here was opening the posterior channels so that we could actually take the drill in from a lateral aspect, because as you know, in those cases, we're dealing with 35, 40 millimeter drills, and we can really run into, quite a bit of issues, both drilling and placement. So this is an option. We didn't do it on this case because I had enough room, but again, this is something that can be done, and it doesn't have to be just printed metal. If you use the traditional, milled or printed guides, you can, easily incorporate this into your treatment algorithm. So here, again, implant placement coming in from the angle. And again, these implants, grade 5 titanium, one of the first companies to do that. Roughened surface, platform shifting, tapered body. And then the micro threads that are really gentle to that crest tissue. Those of you that know me know I love the word gentle in relation to the bone, and the progressive threads to increase the bone to implant contact. And now remember that little jig that I showed you before, that little wafer here, again, critical in digital technology. because we want to save our time here. And so everything that we do ahead of time helps us during surgery. So if you remember those little black marks on that jig, that tells me where my screw is going to be to tighten in that 30-degree multi-unit. So when we look at implant systems, we have many systems out there that work great, but a lot of times the pitfall is the prosthetics within that system. So one of the things that I like about this system is the prosthetics really fit into the implant and are really well thought out. So if you look at this little angle right here, if you can see my mouse, you can see where this little scalloped area, again, helps to manage the soft tissue as well as the bone to get a nice fit. And you can see, I like the fact that it comes in 2 millimeters rather than 3, because many of you know that at times you need that 2.5 millimeter or that 1.5 millimeter, and you have to jump to 3 or you have to jump to 5. But here in this case, you have the ability to utilize the 2 millimeter, which I routinely choose. So here's our pickup. And again, everything stays in place. Jig stays in place, frame stays in place, cylinders here. I decided not to load this one, not because it wasn't stable, but what I didn't want to do was possibly cause fracture to my prosthesis. So again, prefabricated ahead of time. Holes are cut in, pickup channels. And again, in digital technology, you have the ability to match the shade here to the patient's ethnicity. Remember what I said. Let's give people teeth that fit their face and plan it to match what their needs are, not just routine off the shelf. So here you see we're picking up. I left that 5th one out. I didn't want to weaken the structure in here. But one of the things that I found in my experience is that, when we were doing these in a traditional acrylic way, that acrylic, when you lose an implant with acrylic, it's usually when you're screwing out the prosthesis. Rarely do you have a fracture unless you have a long distal cantilever in the molar area if you go over, say, 12 teeth. But what I found in PMMA, when it fractures, say, in here, usually you don't lose the implant. And with digital technology, you can just mill a new prosthesis. So although at times this can be a little bit of a pain, in my hands, in my experience, that's one of the differences I see in acrylic versus PMMA. Think about it. So here you have beautiful prosthetics here, as I like to say, keeping it pretty. You put this in a patient as the temporary, and immediately you see the smile on their face. You show them what they can achieve, which is huge in doing these cases. So here's our final pickup here that we're going to go ahead and insert. Our occlusal jig. And prior to closing, let me step back 1 second here. So you see we still have our frame in place. So we can pick up everything in the mouth with still the frame, still the jig, and then you take out everything, put your healing abutments on, suture up, and these are PRF blankets. And this is the A, if Rick is listening, this is the A. This is not the Bio PRF quite yet. So I'm not there yet, but we'll get there. So here's our closure and radiograph. You can see nice 16 millimeter posterior implants, tilted and axial. We'll manage that in a little bit. And here's a paper to support what we do. It's a paper by Agnini Brothers, myself, and Roberto Apponi. Just came out in Journal of Cosmetic Dentistry, so take a read there. And again, I told you we were going to stage this, so mandible, secure, printed denture. And this is some of the older material, not too pretty, but that's not really the deal here. We've corrected our buccal corridor, and we're going to go ahead and plan the maxilla. So here's Anthony. And let's listen a little bit here.
All right.
Just jump ahead here.
That theory, right? Tell me the difference now versus before we gave you these new teeth. What can you do now that you couldn't do, or what's the difference?
I'll tell you the biggest difference. Having partial in, half the time I was chewing my teeth, not my food.
Important.
Oh my God. Of course, with these, teeth are in place. I can pretty much eat what I want as long as my upper plate decides to hold on.
Right.
But first few months, you want to be sort of gentle with it, not too much. I'm a big popcorn eater, so I'm trying to stay away from that, right?
You haven't had popcorn yet?
No, I'm scared that Colonel getting out of there.
You know what your friend Tio used to say, right? Or get your popcorn ready. Because when we do the top, popcorn time. All right? Don't tell nobody I said it's okay for you, but popcorn probably
every day.
Over Rettenbacher, come on over, right? That's exactly right.
So let's go ahead and do the maxilla. And again, our blueprint, our roadmap, everything we need ahead of time. Now, with the technology, what's really important in this case is that I had the ability to evaluate Anthony's bone before even doing the procedure. As you know, the chemotherapy, the treatment, it does affect the microvasculature similar to diabetes. And so my concern was, could I get him to heal? And yes, I was successful in the mandible, but as you know, mandibular surgery is, the percentages are much higher than in the maxilla. But again, dense cortical bone and good intramedullary hair. So let's go ahead and do the maxilla. One quick step point here. You see this little sinus mucocele here? Now, if you look at all the studies from the ear, nose, and throat surgeons, they will tell you absolutely no issue at all, leave it alone if it's asymptomatic, but make sure that you document it and you have it evaluated. So you can see the overlay of our mandibular denture here, our maxillary denture, getting the right trajectory to get the screw access. And again, same plan as before. We're going to go ahead and use the technology, make sure that they're designing the right way, overjet, overbite, and vertical. And let's go to surgery. And this is that jig that I was telling you about earlier back in the presentation. Here's our frame, connected in, everything snaps in, snaps out. Again, sleeveless, keyless, going right in. And there's our implant driver. Now, one of the other things about this system that I like, it's fully guided. So we're actually even time the implants when we're placing them. And Rick, I squared a little IPRF on these threads. But again, if you look at this small picture here in the upper left screen, posteriors are open. In these cases, very easy to do, very easy to come in from a lateral aspect. And you can see that this is a partial extraction socket shield combination case here where we're utilizing all aspects of this, what I like to call the suite of PET. So we're stabilizing our implants here, ready to go. Our multi-units are in place, and we've done minimal bone reduction here. But again, I tell you, I was very surprised in this case because just look at the overall health of this bone. And, this is a gentleman where 15 years, he's had a disease process, throughout his body. So earlier I mentioned about the prosthetics being the weak link in a system. But in this case, this is quite an advantage because this particular screw that we normally torque to about 15 newtons can go up to 22. Why is that? This screw is 20% larger than the average screw that we find in most multi-unit combinations. So what does that do? Decreases the possibility of loosening because you tighten it a little bit more. So here's our final interim prosthesis in the maxilla. And again, tilted and angled, we know that it works. And remember that multi-unit there? Now tighten it up a little bit. And I like to call this digital hygiene. When I design these cases, what I like to do is leave a little high water here to allow hygiene. I mean, again, you look at this and you say, well, wow, that's a big gap there. But you'll see in the upcoming slides, when we unscrew this, immaculate tissue. And it allows the tissue to, like I like to say, it allows the tissue to breathe. And it allows the patient to really, keep it clean without much effort. When I was doing these cases, the analog way, let's say, you really would have these prostheses that were really close and tight, up against the tissue. And, you put this little gap in this little ledge here, and it just allows the patient hygiene. So let's talk about the restorative journey, okay? And the factors that we face now when we've had adequate healing. The great thing about Anthony is I did not lose an implant. I had no issues whatsoever. At about 3 or 4 weeks, I took out the prosthesis, the mandible independent when he had the maxillary denture in, and the maxilla independent. and no issues. But when it comes to the restorative phase, we have the issue of the digital registration of multiple implants, as well as we know as the number of implants increase, the precision decreases. And we look at precision versus accuracy, and that's another whole conversation there. But we look at the time. We look at the times that we have to spend to take these full arch impressions, the time the patient spends in the chair, and the patient comfort. I mean, think about it. If you have 6, 20 millimeter impression posts in your mouth and you're sitting back in a chair, it's not too comfortable, And again, it's the same thing with digital impressions and the difference between a digital impression and a tray impression. So how are we going to address this? Well, what I decided to do in this particular case is use the PIC dental camera or precise implant capture. And let's go ahead and chat about this a little bit and what it exactly is, because it's different than just intraoral scanning with scan flags. There's a big difference here in the technology. And how does this camera work? Well, it captures the positions of the implants by using photogrammetry. And essentially what that is, it's optical measurement using photos and pre-calibrated code. So photogrammetry is a whole different science that's been around in other industries for a while, but using it in implants now and these pre-calibrated code is the actual key. Because essentially what happens is the inventor, Adrian Hernandez, designed these special coded abutments, and you can see these little flags here and these little circles that actually, when you take the pictures of them, those help to align and actually extract the angles and the distances between the implants. And what does it do too? It also eliminates the need for impression copings, analogs, and impression materials. So all those things cost money. The camera's not inexpensive, but again, you have to look at the value of this over time. So where is there a little bit of a difference here? What do we need? Well, we need an intraoral scan of the prosthesis in the oral cavity. We need an intraoral scan of the soft tissue as a separate file. And this is really the key here because, one of the errors that or the factors that we encounter is the more we have to scan, go back, scan, we increase the error factor here because of all the stitching. So when we have 2 separate files and then we're able to combine them, that's where the key here is. And again, implant specific. So whatever system you use, whatever connection you use, the flags are specific for that system. And then we're going to export all these files. We're going to merge them. But let's just do a quick little demo here. Here you can see. And so what we've done ahead of time here is we've placed all the information in the computer. And now we're going to go ahead and scan. And these little green bars indicate the position of the implants and filling it up like a battery charger on your phone. And Adrian was so nice to actually come to my office to help me with this, to help me understand the technology. And I paused this video and I'm going to show you this one because as you can see, the red means that we didn't pick it up quite yet. But as you can see, he's going to put his hand in front and we're going to turn it so that the camera picks it up.
Now that this is recorded, I will put my hand here. I will go here.
To get the difference like we did in.
All right, so then you can see this is how it looks with all the bars filled here. And again, in the posterior flags always point towards the lingual or point towards the palate. And there are specific positions that we enter into the computer, into the software initially, kind of as a guide as to where to read. If you look on the counter here, you see I'm already ready. This is way back before we're going through this epidemic. You can see I've got 1, 2, 3, 4, 5, 6 different types of disinfectant on the counter. And when we reopen, that'll all be gone. There'll be nothing on the counters now, but we were getting ready. So what happens next? All of these files are now exported to design software, be it Zircon-Zon, ExoCAD, 3Shape, And then we want to talk to the patient, and we want to make sure that we have both our aesthetic and our functional needs met in the prosthetics prior to fabrication of the new prosthetics. And I like to say, when we fabricate this, the patient's going to test wear it to work out the discrepancies. So let's go ahead and look at our files. This is the zircons on, and this is our soft tissue scan. And again, look at the accuracy here. Look at the accuracy of these intraoral scans. You can see the rugae, you can see the keratinized tissue, but you can also see where the multi-units are and the soft tissue adaptation around them. Take a look here. Let's go back. When you look at this, you can't see really any of those multi-units sticking out here, can you? So knowing that, remember I told you about the design, the scallop design allows that soft tissue to really adhere to it. So we take a look there. And then this is our intraoral scan of the current prosthesis that the patient's wearing. And we're going to go ahead and make our corrections. If you take a look here, a little open to the posterior. And I still think we can get a little increase in the buccal quarter here. There's several papers out about that we can reference later. And just the occlusal surface. So now here's the key. So from the PIC camera, this is our file, okay? And we're going to go ahead and match those to the intraoral scans. So here you can see the multi-units here. And we're going to do that by what's called a best fit algorithm. So similar to if you think about how we look at CBCTs and intraoral scans and how you pick points to match them before you're going to make your surgical guide, a little bit, that's kind of the best, similarity or best example I can give you. But again, this is all algorithmic, all angles, high-tech stuff, guys. And again, our little color map here showing you how accurate our mapping is. Purple is good. And then this is our digital wax up. You can already see the teeth have been lengthened. The vertical is increased. We're going to go ahead and add some pink. And I think, Mark, on this side on my screen, we're covering the little table right here. That's fine. But what I want to show you is that if you can see this, it tells you each step that we're doing. So it tells you, these little boxes kind of tell you where we're going through the workflow. And this is what the lab technician, is doing along with your, with your input. So this was our original file in the aqua or the teal, and then overlaid over the new. And remember now, again, we've corrected, I had my digital hygiene here, but we've corrected this now, but still, if we were to look at this intaglio surface here in close up, we still have hygiene possibilities here. Screw access channels, very nice. Nothing coming out through the incisal edges or cusp tips. Mandible. We're going to go ahead and mill this out, and we're going to cement in some tie bases into those channels, and again, have the patient test wear this. And here's our interim prosthesis. This Rafa Santrich down in Aventura. Here's our maxilla and our mandible. And unfortunately, due to COVID, this is like where we are right now. I was supposed to insert this the week that we were mandated to shut down. However, we have another case that's a little bit ahead in the treatment. And like I said, superhero always has a backup. So as a backup, let's take a look here and see that we can do similar here with the partial extraction therapy. And this is a full arch partial extraction therapy. And you see root submergence, Henry, socket shield, root submergence, socket shield, root submergence, socket shield, edentulous area, and socket shield. And when we look at that from a scallop technique, and we look at the paper here, published 2018 with Maurice, Alessandro Pozzi, Wendy Auclair, Marco Lars, and Pincus. And it was Wendy, if you remember, Maurice, it was a course that Wendy was doing when she was still with you that I attended and kind of got the whole vibe of this deal and, incorporated it into my workflow. And so we're looking at, patient-specific implants here and essentially scalloping the bone. Remember what I said, bone that needs to be left alone, okay? Tailor it to the actual patient, bespoke technology. And This is for my good friend Marcelo Ferrer, 336 hours, which is 14 days. So, and look at this soft tissue. I mean, remember how this looked. This was wide open. But again, we were gentle to the bone, gentle to the soft tissue, and look at that result. So now we're going to go ahead and scan that. Same thing here. Posterior flags in towards the palate. We left this one out because of proximity, but we'll come back and put it in. We'll scan. The beautiful thing here is we can still pick that implant up. We just have to remove a flag out of the way, put a new flag in because we have our baselines and we're going to be able to pick that up, no problem. So here's our test wear with our passive fit. Look at that occlusion, allowing the soft tissue to develop. Again, these are interim prosthesis. Again, yes, this is a second set, but why go final right away when you have the ability to continue to develop? This patient's tissue responding quite nicely. So let's take our time. There's no real rush here, no real rush. And we can end up with a result like this with full arch partial extraction therapy if that's the indication. So here's our literature to back up the technique. And if you can't read any of this, just shoot me an email and I'll, supply you with whatever you need. Mark, you remember that picture?
I think, when was that? That's in New York, isn't it?
I actually think this was in Miami about 3 years ago, I think. So,
okay. Time flies.
So, but I'd just like to thank you folks for inviting me to do this. It's been an honor. DentalXP, this kind of made me get on Facebook. Well worth it. Canadian Implant Dentistry Network and Ritter Implants. And, in the digital way of things, this is actually a photograph that was digitized. So, just unlimited capabilities is what I like to say. So thank you folks so much. I greatly appreciate it. And let's stay safe.
Richard, that was so good, my friend. Thank you so much for sharing your experience with us. As an oral maxillofacial surgeon, that you have so many different referral people of different experience levels. And when you started to recognize that they needed guidance and that you started to recognize if I'm going to work with a referral-based network, I have to learn the prosthetics. I have to learn the digital so I can become a better resource to those colleagues than just simply being an outstanding surgeon, which you have always been. And I remember you coming and always sitting in on the restorative parts of the lectures, getting involved with digital probably earlier than most oral maxillofacial surgeons that I know. And I think you can see it clearly from what you displayed today. Some of the questions that I'm seeing that are being sent in, one of them is that you made a comment regarding the Ritter system, and I think Alain, I know, has some experience with the system as well. A true tapered threaded implant that has the micro grooves and a platform switch is more suitable for these types of procedures where, with Alain's situation where he's trying to do immediate temporization, in your case where you're doing immediate loading. Are you looking for that system to provide additional stability because of its shape and threads? And are you placing it subcrestal? The question was, is that allowing you the versatility because of platform switch capabilities to place your implants more subcrestally to compensate for any resorptive changes that occur?
Yeah, good question. And you actually, I think you already answered the question by what you said. But yes, it's why I chose this system, because of the progressive threads, the self-tapping ability, the platform switch. The design of it just gives you in my hands, gives me a higher initial torque. As you know, with some of the larger diameter implants, you actually sometimes have to back out the implant, do a little bit more prepping and reseat it. And yes, always subcrestal, always subcrestal. And because of the platform switch, it allows me to do that. And in case I have a slight bit of resorption, I'm covered. You know, in the old days when we were doing these full arch cases, we always placed the implant crestally or you know, at the crest, because we didn't want to have to ream bone from around it. We would go to place these multi-units in, and the multi-units would bind, and they wouldn't seat. And we'd take like 5 or 6 x-rays and we'd take it out. We had these special bone reamers that we would put a little piece into the implant, ream around it, you know, and then we'd come back a few years down the road and we'd see exposed threads, you know, and just like if we were doing anterior teeth, like in Alain's case, you know, we always want to place the implant in the anterior 3 to 4 millimeters below the CEJ of the adjacent teeth. And so in my hands, I follow that. I don't go, you know, 3 to 4 millimeters, but at least 2 millimeters below the bone crest, because I know that I have reliable prosthetics.
Absolutely. Absolutely. Another question is in relationship to the prosthetics. You were mentioning how you then transition the patient into a test drive prosthesis. Is that a milled or printed prosthesis? So you're going through a conversion prosthesis, then a secondary temporary. So in the end, you're going through 2 different temporary restorations.
Yes.
Can you explain that a little?
Well, yeah. So, you know, because remember I like to say the first temporary is essentially, again, I'll use the word best fit, not like what we do in the PIC, but it's a best fit. It's like an immediate denture. We've increased the vertical, and, you know, we're seeing how the patient tolerates that. And although I said, yes, we can design the smile to fit the patient, it's not perfect. And again, that's what we are looking at. But the goal of the second temporary now is to work out all the little imperfections to make sure the patient likes the tooth shape, the tooth form, make sure the overjet, the overbag's right, make sure when there's smile, the lip line is in the right position. The patient has a lot more input in the second set. I would almost want to call that, you know, the patient input set of teeth. And you want to work that out before you go to final zirconia or whatever material that you use, because you don't want to go straight from, you know, your initial interim to a final zirconia. You want to see how is the patient going to tolerate that. So yes, you know, you do go through 2 sets.
Okay, and you mentioned about the prosthetic screw for the multi-unit being slightly larger, and
yes.
And because of that, being able to torque it down to a slightly higher torque. Have you seen, because at least in my experience, I've seen both of us have used many different systems and continue to, I don't see the screw loosening issues that I've had with other systems, and that there is a benefit to having that slightly larger multi-unit abutment screw.
I haven't seen that. I've done several of the full arch with the system, and I don't see the screw loosening. I don't even see it in my temporaries either. I mean, in my hands, that, you know, if you do the math and you look at what is the difference of 7 newtons, you know, between the 15 and the 22, I think that's 7. If you look at that and you calculate it out and you put it on a strength curve, you'll see where 7 newtons is quite a bit of additional strength in tightening for any of the mathematicians, you know, listening here.
All right, so somebody asked, since the PIC is supposed to be so accurate and provide such a passive fit, is it still necessary, do you feel, for all cases that a second set of provisionals is required, obviously because of the cost to the dentist, or do you pass that on to the patient?
Well, I mean, tell me how is everybody doing their cases now? Even if you take when you're doing digital technology, if you take, you know, traditional analog impressions, you still, I mean, that's where the word test drive came from. The word test drive came from a set of provisionals that the patient wears to work out all the discrepancies, especially if you're using zirconia. I mean, you know, those of you in the group here, tell me, do you go straight from one, you know, to the other? Because again, you may put that zirconia in a patient's mouth and they may say, well, I don't like that incisal edge. I don't like, you know, it's again, it's just, you know, if you're spending this much time, you know, and again, many a times those interim provisionals are $700-800. I mean, in the big scheme of things, that's not a lot of money. When you're charging a patient $60,000, $70,000 for a dual arch case.
I completely agree with you. We do that routinely, and we build it into the cost of the case. I think you absolutely need to go that route. We typically, as you know very well, because of fracture of printed PMMA, we've moved on to, as you showed today, milled, which I think is certainly much better. If you're going to do PMMA, obviously out there, those of you who are still using printed PMMA, then you really do want to reinforce it with a bar, which is what we suggest. Have you had a chance to use the narrow line for full arch case yet? Because I thought that's very interesting with the grade 5 titanium being able, FDA approved here in the US, to be able to do 3.0 and 3.3 diameter implants with multi-units that fit, so that in cases with very narrow ridge form, which a lot of these edentulous patients or full arch patients have very little ridge width. Have you been able to utilize that? And you see it as a unique part of the system?
So I'm going to answer that quite eloquently. Can I still scroll back, Mark?
You can go back to your presentation.
Yeah, let me show you something here. If you actually look at this case right here in the upper left corner, Maurice, this is the famous ice in the veins case, and this is actually utilizing the narrow line also. I use a narrow line on this case in several of these implants, and essentially what happens is this frame clips off, and we clip in prior to this, or you clip in another frame to drill for the narrow line. So yes, I've used a narrow line, for that purpose.
I know Henry was back in the day one of the first to publish a series of cases, 30 cases, at the University of Pennsylvania, doing this in an analog fashion. Henry, when you look at how this all became transformed into a fully digital, fully guided concept, and you look back at your papers published in 25 years ago, when you did this in analog fashion, what are your perspectives? How do you look at what Richard displayed today?
I mean, it comes down to actually a concept which is an interesting discussion when Richard talked about precision and accuracy. We got to a level of accuracy. This is taking it to a level of precision that is quite remarkable. And certainly a lot of the work is done prior to the clinical setting. But while you're in the chair, while you're doing the work, it certainly saves a great deal of time. And it's the same planning, is just now done in a much more eloquent and precise way, I believe.
Absolutely. Mark, I know that you started doing quite a bit of these cases in Toronto, and I know that you have some experience with the system as well. Any comments you'd like to make? Any questions for Richard?
So I've used both the Ritter line and a number of implant systems. The Chrome Guide's actually been my go-to for full arch right now. And I started to transition to try and incorporate PET into it as well. So I have a few cases waiting post-coronavirus to restore. And I think the result with these two together is, it's going to be an evolution in how we do these kinds of cases. So it's great to see Richard presenting this for everyone to see it.
Yeah, I think it's pretty amazing also the ability to utilize, I know, multiple labs. There's a big question for those out there that are watching, and we got quite a few, is to pick something that makes sense to you, that is cost effective, that is precise, and that the system from start to finish allows you flexibility. And I think, Richard, you did an amazing job displaying all of those things in a very short period of time. Again, following with this being a mini symposium, I'd like to thank you. I think you did a great job. I think we got so much information, and I would like to let you know that you're always one of our favorites. So it's been a pleasure to see you on Facebook. I know a lot of people are shocked, and we look forward to having you back, being able to see you soon in person, And it's time, I guess, for us to get to the next speaker, Mark. So let's go there. Thanks, Richard, once again. Great job.
Thanks, Richard.
Thanks, guys.
Okay.
Thanks, guys.
So we'll get the next person in.
Very interesting. You know, Henry, one of the questions is kind of like reminds me of what you were doing at Penn when you did your research, your clinical research on immediate loading. There's about how you get your facial occlusal proposed changes. How do you use your pre-op occlusal rims, time in the chair, video, phonetics, aesthetics. Those things don't go away even if we enter the digital realm. So.
We got Bassam here now.
We didn't have narrow diameter multi-unit abutments back then. It actually allows you not to have to remove as much bone as we did to get, you know, at the time we were using Straumann, 4.1 was the narrowest that we had with that particular system. So it really changes the whole dynamics of how you plan out a case. So I found it quite amazing to have that luxury of using a 3 or a 3.3 millimeter implant.
Yeah, I think so as well.
Assam.
The next speaker, why don't you do the introduction to this wonderful man?
Well, Assam, Robbie, everybody, a wonderful friend for many, many years, and we've had the pleasure of visiting with him in Egypt quite a few times, and many of you know Maurice and I and Eddie and our whole family were born in Egypt, and had the pleasure to have him host us a couple of times. I always knew he was a wonderful gentleman, a good friend. Over the years, I've just seen how incredibly talented he is, especially as a teacher. And I think I'm really looking forward to your presentation, Bassam.
Henry, Maurice, and Mark, thank you very much. It's really a great honor and a pleasure to be with you guys right now with all my friends, Alain, Martin, Rick, Alvaro, and Dean. And I hope you guys are safe and sound, and I hope this pandemic really fades away very fast and safely for all of us. And really hope all of us are going to get back to our lives and our practices, which we really miss. I haven't been working for the past 5 weeks now, I guess just like you guys. Hopefully soon everything will be fine. Just to get into this topic, cosmetic and functional stability around implants in the aesthetic zone, I just wanted to start this presentation with these two pictures. The above picture is, and the lower one, the above is a case I did almost 21, 22 years ago. And the lower one was around 18 years ago. And at that time, as a prosthodontist, really never really focused about anything except, you know, extracting, placing implants, and maybe 96 at that time was the time that it started the extraction socket implant placement immediately. And when I started this, for example, these two pictures, the upper anteriors, immediately extracting them, immediately placing the implants and restoring them. Are they still in function till this moment? Fortunately for me, they're still in function, but is this a cosmetic and a functional, stable implant treatment plan? Look at the tissues. Never really focused on the soft tissue and the underlying bone, whether we have keratinized band of soft tissue or good amount of bone in front of the implant. I don't even remember, as I recall, at that time we weren't really taught where to place the implant. I remember just placing the implant in the center of the socket when you extracted it. Whether you had a gap, fill it, I don't even remember if I really filled it with any biological material at that point. And when we talk about extraction sites in the aesthetic zone and the stability around these implants from a soft tissue point of view and a bone point of view, now comes the question, do we immediately extract and place the implants, do our grafting, whether it's bone, soft tissue, everything, and then restore it, and where we have good stability around the implants, and what's the real clinical outcome after we load these implants. So just showing, I don't know if you can hear me. Can you hear me, Maurice and Henry?
Yeah.
Okay, good. I just put the sound off for the music for this video. So to assure the stability of the tissues around the implant in the aesthetic zone, especially in cases of immediate extractions, there are several questions we have to ask. Do we need certain surgical techniques? Do we need certain instruments using certain microblades? Do we need certain sutures and biologics? Do we need approaches that are minimally invasive? Do we need to do the soft tissue grafting and bone grafting immediately after extraction with the implant placement or before the implant placement? Do we need temporization of these cases, whether we place the implant just to have this soft tissue architecture and preserve it as much as possible? Or do we need more intervention later on? Even if we're not placing the implant, maybe we need to develop the site of the implant itself. And do we know the influence of the healing of these tissues using these surgical techniques? And what if the tissue response is not in our favor even before loading and restoring these cases? So many questions. And when I look at the factors in implant dentistry, which I learned basically from Mo, Maurice, and Henry, and others, of course, on DentalXP, there are three major factors: bone, soft tissue, and the implant. Implant design, don't forget, it's a very significant issue in implant biomechanics. And when you look at this upper left side of this slide, this is a photoelastic stress and strain analysis of the implants, and it shows you the amount of stresses that is actually concentrated mainly on the first 2-3 millimeters of the head of the implant. We know it's around 60 to 70% concentrated in this area. And that's why when we choose implant systems that we need to have a platform which has this 2 millimeters with micro threads just to reduce the amount of stresses on the circumferential bone contact and lessen the amount of stresses and maybe stabilize the crest of bone around this area, which always is the big issue. Already Alain pointed out, when we extract, we all know from the work of Lindy and Nevins, once you extract, you don't place anything in the socket, you lose the labial plate because of the blood supply that you lose from the tooth itself. Even if you graft with some material, we still have around 20% of remodeling in this area. Another question comes in the extraction sites. What's the implant diameter that we have to choose? It depends on two factors: the gap size that we need to leave in front of your implant and the socket size that you're dealing with. And do we graft this gap or not? As I said before, I don't remember we used to graft or not. Some people don't graft, they just leave the blood inside. But definitely there is going to be some kind of remodeling and you lose bone in some tissues. Again, another question: labial thickness. We all know it's less than 1 millimeter. And when we are placing implants in the aesthetic zone, we all know we have to go more palatal, leaving this gap because we need the 2-3 millimeters in front of our implants. And sometimes when we don't do this, what do we end up with? An integrated implant, whether it's with a graft or not, but it's placed in the middle of the socket as I used to do 20 years ago. We end up with full bone loss of the labial plate, although it's an integrated implant. And we know the study that Joseph Kahn did in 2012 in Jomi, in which he concluded that after 1 year of loading, placing these implants in the proper position, more palatal, leaving the gap, grafting, and loading, you still get some changes at the crest of the ridge in front of your implant, around 1.2 millimeters of bone loss in this area. So now, what is the gap? If we have thickness of the labial plate is less than 1 millimeters, and we have loss and remodeling of this area around 1.5 millimeters. So we need a gap which is more than 1.5 millimeters. So what's the implant diameter? Well, going back in a buccolingual dimension example for a upper central incisor, when we extracted buccolingually, we have like 7 millimeters in dimension, while the mesodistal dimension is around 9 millimeters. I remember, again, like 15, 16 years ago, these cases I used to use these large diameter implants to try to fill the socket. But again, when you start to think about it, the labial bone is less than 1 millimeter. We have loss of the graft with the graft, the remodeling effect in the buccal aspect, which is around 1.2 to 1.5. We need more space in front of the implant, around 2 millimeters. So the implant diameter that we use is less than 4 millimeters. As a matter of fact, in most of the upper central incisors, when we extract them, I use around 3.5 to 4 millimeter, whatever implant system we're using. Now, this is an article, I think it was 2.5 years or 3 years ago by my friend Harry Gluckman, which is a very interesting article regarding the guidelines for initial osteotomy preparation. When you're immediately extracting this, you want to know the radial plane tooth position in your socket in a buccolingual dimension, because you have all these scenarios. And from the cone beam CT, like you can see in these first 3 pictures, the upper and the lower left, we have very good amount of bone palatal, which we will know and we can plan from the beginning. Going to extract it, place the implant more palatal. We're going to get very good primary stability, especially when we're using certain implant systems which have very good primary stability, like the Ritter implant, which I'm going to show some cases in it. And you have these cases like the lower right side where you don't have any palatal bone, very thin labial plate, an apical infection. So these cases, we know from the beginning, what we need to do is just we need to first graft this area and then properly place our implants in a 3D positioning properly. So for example, this case, just to show, I'll show it later on, you can see the buccolingual dimension, even after extracting and grafting, there comes the time which I think freehand implant placement is not there. We should use guided surgery in cases like this, even if it's just for single implant placements, because you need to place the implant exactly and you want to leave the amount of bone in front of your implant. So let's go to some cases here. This is a case, I started working with the Ritter implant system maybe 5 years ago. Around 4 or 5 years ago, as I recall, one of the very good systems. So this case was one of the first cases that I used the Ritter system. You can see here in a cone beam CT, the buccolingual dimension, the amount of destruction of the bone, the apical infection. And when we actually start, we know we're going to be placing first the bone graft, if we're going to do any soft tissue grafting before placing the implant. You can see the upper central here is vertical fracture of the root with some infection, and always trying to be minimally invasive in the aesthetic zone, trying to preserve the soft tissue, trying to preserve these tissues in this area, taking a connective tissue graft, tunneling, placing bone. And at that time, maybe 5 years ago, I was still placing a mixture of allografts with xenografts, and then immediately sealing the socket with a free gingival graft, giving more vertical height and quality of the soft tissue, and immediately with CAD-CAM temporization with a cantilever ovate pontic on the area to develop the site of this implant. As you can see, the lower left slide here showing after 6 months how the soft tissue has been preserved, the contour labially, the papilla between the natural root canal tooth and the future implant site, how it's been preserved. Again, 2 studies by Thomas Limkivakis, which I'm sure everybody knows it, just showing the influence of the design of the implant and the thickness of the tissues. So in one study showing that even when we're using platform-shifted implants or platform-switched implants, although you still give this horizontal dimension for the bone to grow. If you have very thin mucosal tissue, you'll still get bone resorption around these platform switched implants. While in another study, he showed that when you're grafting with soft tissue grafts or dermal matrix, like Alain has showed his cases, even in cases where you have the normal platform not shifted, you will get stability of the crestal bone. So either way, using dermal matrix or taking a free gingival graft, deepithalizing it, either way, always in the aesthetic zone, at least myself, I would say 90% of my cases, I always do these soft tissue grafts. So now placing after 6 months, and remember I said I used a 50% xenograft with allograft, placed a Ritter implant. At that time I used the osteodensification just to try to densify the bone. I got very good stability, but wasn't comfortable enough to immediately temporize the implant. And I think this is also, I got it from Maurice, because the implant is very tapered and it has very good stability. I think sometimes you don't need to osteodensify the bone in these areas. But again, it's because the xenograft and the allograft after 6 months was not enough, I think, just to get this very good primary stability to immediately stabilize it or temporize it. Now again, doing another soft tissue graft, taking a free gingival graft. Part of it is deepithalized, which is going to be tunneled labially and placed inside, as you can see, while the other part, again, I'm putting it to seal the socket on top of the implant or seal the osteotomy site on top of the implant to give more vertical dimension of the soft tissue, and placing back the same CAD/CAM temporaries that were used. After around, I would say, 2-3 months, I leave it and then open. I never open flaps. This is a technique I learned again from Maurice, the roll technique, trying to remove the epithelium microsurgically. Just going to go fast in this. And after removing the epithelial layer above the implant itself, you have a connective tissue layer, which you want to actually cut it down to bone, except the labial part, and then tunnel in front of your implant, and then elevate this piece of connective tissue. And I have a height of around 3 millimeters of vertical height of soft tissue, and then I place my piece of connective tissue, just roll it inside in front of the implant to give more soft tissue thickness in this area. And I think, as Alain has showed, and I've seen it in many cases again, that connective tissue grafts, when you really give good thickness in this area, they tend to grow more and more, but it's always better to have more than less. And since I'm doing a lot of digital and CAD/CAM in office, I've been doing it for 10 years now, almost 10 years. So in this case, I temporized CAD/CAM screw retained on the implant itself and on the natural root canal adjacent to it, and left it for another 6 weeks. You can see the quality of the soft tissue just to heal. I always try to give time as much as possible for the soft tissue. And a cone beam CT, you can see the amount of bone in this area in front of it and the soft tissue in front of the bone itself. Now, after another 2 months, almost 6 weeks to 8 weeks, I remove the temporaries again, and now I go for the CAD/CAM tie base on the Ritter implant and do my CAD/CAM Emax with cutbacks. And as I have in my office and in-office lab, I have my technician here doing the lab work and doing the build-ups with these cases. And you can see this lower picture here is the time of delivery, and above one is 5 years after, 4.5 years to 5 years after. You can actually see the quality of the soft tissue. As a matter of fact, you can see that there is more soft tissue growth on top of the implant itself. And on the left side, the quality of the bone. Again, you can see the bone in front of the implant. It's more radiopaque because, again, remember this is 50% xenograft with allografts, which part of the particles are still there inside. But very good stability of the bone around the implant and the soft tissue itself. Now, as I said, of course, the next speaker, my friend Alvaro and Dean and Richard have been talking about digital, and they're still going to be talking about digital, so I'm not going to go into this, but it's very good when you have in your office all these tools to support your treatment. This is the case I showed a while ago, that I'll just go through it. So this patient, she comes, this was like 4 years ago again. The buccolingual dimension, as you can see, there's no bone in a palatal dimension that I can actually plan to extract and place the implant with good stability. So decided again, we need to do some bone grafting and place this implant with a guided surgical stent. So showing this, this tooth, the upper right central, removing it, you can see a fracture, vertical small fracture in this area. And I was once giving a lecture on this, and someone asked me again regarding socket shield, which I do sometimes. But in a case like this with infection apical to it, and then in a buccolingual dimension, I felt it's better just to remove this tooth completely and place a bone graft material. And maybe you saw this piece of white, this is a dermal matrix, which instead of taking a free gingival graft, just to close this and seal the socket itself. So after properly suturing it inside, and just want to show you the labial aspect of these tissues. We have very good keratinized tissue, and that's why I decided I don't need to do any connective tissue in this area. And after suturing it and then leaving it for around 4 months, look at the amount of tissues in the labial aspect, in a crestal aspect, and the papilla between the future implant, which was going to be placed, and the adjacent root canal tooth again. We have very good, robust tissues in this area that we didn't need to do any soft tissue grafting in this area, except for closing the socket itself. So again, the same concept of deepithelizing these. I don't like to open the flaps microsurgically, deepithelizing the epithelium in this area. As you can see, removing using surgical, microsurgical instruments and blades, and then rolling these connective tissues, and then using a guided, immediately milled in my office, and guided surgical guide stent, placing the implant. And then immediately using tie base, CAD-CAM milled PMMA temporary, cemented on the tie base and screwed into the implant. And after a few months of healing and integration, you can see the quality of the soft tissue. The patient was looking at the laterals, and she was starting to think she wants to do some cosmetic work in it, but she didn't really give the answer. So I chose to do on the two anteriors, the centrals, the implant and the adjacent tooth, 2 Emax crowns as temporaries until she decides for the laterals if she needs to do any veneers or crowns on top of that. And I left it for 6 weeks for further maturation of the soft tissue and the papilla. And now after 6 weeks, I removed, she decided to do these laterals, took a soft tissue scanning of this implant, the Ritter implant, to try to capture this soft tissue inside as much as possible. And immediately designing, while the patient is sitting in the waiting room, immediately designing the CAD-CAM screw retained temporary on the implant, the veneers, the crowns on the adjacent teeth, and immediately trying it in with the Emax, and then delivering in the same visit everything. So you can look at the CT, this CT on the right side, showing the implant. This was like, I think, 5 months ago. You can see the quality of the bone, the amount of bone in front of the implant, and the soft tissue integration above the bone in the platform switched area, and how stable it was. Going to another case, this guy, he was graduating in Madrid, in Spain. He's an Egyptian living in Madrid, graduating university. And he was in a visit to Egypt to visit his parents, and he came with this fractured upper left lateral. You see on the CT a horizontal fracture. And again, just the dimension of the buccolingual area, and this is a lateral, remember, doesn't give me the the fact that I can do a socket shield in this area. So I decided immediately to remove it and place an implant. And here, Maurice, I used the narrow line, the 3.3 millimeter implants, which again, as you said and Richard just said, very strong, high grade 5, grade 5 titanium, very strong. The connection is very strong. I've been placing these narrow implants for a while now. No screw loosening, no fractured of the connections like other implants, which I did have many times before. And you can see the recession on the lateral, which the patient didn't really focus or didn't want to have anything addressed towards it. All he wanted to do is place an implant and immediately temporize it so he'll be able to go back to Madrid for his graduation party. So what we did is we extracted, immediately placed a 3.3 millimeter Ritter spiral implant, took the natural tooth of the patient, did a screw retained on it, nothing regarding the recession. He went back to Madrid, graduated, came back. Now it's integrated, decided that I'm going to do something around the recession of this implant. He didn't really want to focus on the other recessions because he had the upper 6 recession, anterior teeth were recessed, and he had some soft tissue grafts done like 4 or 5 years before. He didn't really want to do anything about it. So I just addressed it that I'm going to do it on the implant itself. Changed, of course, the crown to a tie base, PMA, immediate screw retained, tunnel, placed my soft tissue graft, sutured. After another 6 weeks, here's the healing, and took another optical impression and done the final crown. You can see how the cone beam CT is, and there is soft tissue, the stability around the soft tissue, around the implant, around the papillas, everything is there, minimally invasive, never opened the flap, nothing, using the right tools, the right implant diameter. Last case, but not least, just to show not just in immediate extractions in single cases, just a very quick case. This patient, a very beautiful young lady, 26 years old. That's how she came. Look at the amount of bone destruction, the decay under these restorations that she had for 5-6 years. So decided we're going to remove the upper left lateral and central and immediately place the implants, place bone, place soft tissue, and temporize on the right lateral and central with cantilevers. That's the only way we could have done it. And we wanted to address the recessions and the amount of bone and soft tissue loss. So placing these 2 implants again after extracting to Ritter spiral, very good stability. And Maurice, this is the 3 millimeter, the upper left lateral, that's the 3 millimeter, not the 3.3. And the central is a 3.75, giving good horizontal dimensions in between with a platform. And placing the bone, tacking the membrane, sausage technique, closing after 6 months of healing. Now again, minimally invasively opening, as you've seen in the videos before, the on top of the implant, the soft tissue. You can see again the quality of the keratinized tissue in this labial aspect of the implants, and doing some CAD/CAM work on these implants just to try to develop the soft tissue and guide the shape and the scalloping and part of the papilla if possible. And after another 6 to 8 weeks with these CAD/CAM temporaries, now the final crowns on top of the implants and the natural teeth. So we start with this and we end with that. And with this, gentlemen, thank you very much. I hope I was on time as much as possible. It's a great honor and great pleasure, and really miss you and hope we get to see each other soon, whether in the States or somewhere in Europe or in Egypt. Thank you very much.
Hassan, that was excellent. I mean, really beautifully put together. That last case is just one of the most challenging cases I find in the world of implant dentistry. Being able to manage the positioning of the implants, the bone in between, and the limitations. My compliments. That was just beautifully handled and managed. What people may not know is that you're classically prosthetically trained here in the United States, and then I got a chance to see your growth as a perio microsurgeon over the last decade. and had the chance to teach with you actually in Egypt. And it's wonderful to see you. You become so natural at it. You become so, it seems like it's just very, very routine for you to manage the soft tissue. And I know that you have your background in prosthetics, and I just think it was nice for me to look just to see how well you manage the tissue and the bone, and be able to do that knowing that your original background is in prosthetics.
Well, Maurice, I really appreciate what you're saying, and I have to say one thing is, I don't know if you remember in 2005, my first soft tissue course with you in San Francisco. And maybe after 2 or 3 years later, I got to meet Henry in Egypt, and that's how our whole relation got to get together. And I mean, I've been learning from you and Henry a lot of things, and of course through DentalXP, because I've been with you guys in DentalXP over 10 years, I would say. I know it's more than 10 years. It's not really officially 10 years. It's more than 10 years. And it's a great honor to be one of your students and hear what you have to say for my work. I really appreciate it, and I'm really humbled with these words.
You deserve it. And I mean, we always talk about this XP family, and I'm looking right now at Mark, and he's been adopted, whether he likes it or not. You guys know that you have 4 Egyptians on the screen at one time? I think that is
it's true.
A national record.
Yeah.
That's the record. And we have so many more in the balance with Sharif, Saad, and we have Musa, and there's so many. A lot to be proud of such talented people coming out of Egypt. We already know so many talented people coming out of Italy and Spain and Brazil and Canada. And it's really wonderful. And just even in this short mini conference that we're doing and looking at all the speakers and their origins, we have Lebanon, we have Egypt, we have Greece, we have Jamaica, we have Colombia. It's really amazing with all the countries when we try to really truly be international, and to see the talent and everything that is around the world, and to bring everybody together. It's really special. I want to ask you, because there was 2 questions that I'll just bring out, and I want you just to give me some ideas. Number 1, somebody asked, have you attempted, or what your thoughts are on dentin grinding? When you take out a tooth, have you thought of, considered, or used ground down the extracted tooth as a bone graft in these cases?
Personally, I haven't tried it. I haven't attempted it. I didn't get the machine itself, but I can see from a lot of colleagues and fellow educators and researchers that it's working perfectly. But for me personally, I haven't tried it. I prefer, I think it's something, a personal preference, to go with bone grafts, biologics, whether allografts, autogenous grafts. I stopped using xenografts only. I use them, as you always say, veneering grafts. That's what I use them only for. But dentine, no, I haven't done it before.
Yeah, it's very interesting because, we started implementing in my office. I know Mark has some experience with it as well. Snezana Paul has a tremendous experience, and there's many, many others. And it's good to see that research coming out. I think that was something that, we needed to see the histology. We need to see the post-ops. And that may be something in the future that may be of interest. And second thing, and I know that Henry probably agrees with me on this, you seem to have cited, after Alain's first presentation this morning, you seem to like and prefer autogenous connective tissue, more of the tissue that you take from the area with your incision designs on second stage, and autogenous classic subepithelial connective tissue. Can you give us your viewpoint on those grafts versus acellular materials or xenographic materials with soft tissue?
Well, I actually started, of course, with both the connective tissues and the subepithelial connective tissue, which I learned from you first. And then I started using the Zucchelli technique, which is easier, and I can see it better quality. And I did use some dermal matrix a while ago, but when I used them, that was the time when there was the alloderm, as you, of course, already know that if you have it exposed, you get infections. And I had a lot of complications, honestly speaking. especially when I'm talking in my region in Egypt and the Arab countries in the Middle East. Again, the hygiene is not that perfect. Patients are not, to an extent, cooperative in the hygiene or the post-surgical hygiene measures. So I really shifted to more connective tissues, which again, Alain, maybe he said in Lebanon, most of his patients don't have enough tissues in their palate. Well, apparently in Egypt it's different. You know, they eat full medammet, so they have very good. They have very good.
Well, Henry from Molokai, he has a very thick palate.
See, that's what
How do you know?
So one last question. I think that this is something I think Henry and I, because we came to your office several years ago in Cairo. By the way, it was one of my favorite trips of all time. You were one of the really just wonderful hosts for us, and we can't thank you enough. But your office was so special. For those that don't know Bassam, and he has his institute, and he has his office in Cairo. He has 2 offices now, and he has his CAD/CAM milling unit in the reception area. So the patients in the waiting room can see the technology, and it was very interesting to see how the patients really were enamored by it. So when you were using, like, let's say this last case, which is just so pretty, I'm glad you left it on the screen. You placed the Ritter implant, you used their scan body, and you scanned it, and you can manage the shapes. Have you used it as well for doing temporaries with that technology, since it's in your office and you've had it for so long? Have you used that to design shapes, submergence profiles, to kind of manipulate the soft tissue that you so beautifully manage during surgical aspects of treatment?
Definitely, Maurice. I mean, in the aesthetic zone, as much as possible, to be transparent with you, if I have the time, the patient has the time, and the finances, definitely, I try to take my time in developing the subgingival part, or as you say, the emergence profile part, using CAD/CAM temporaries. Because on the software, it's really interesting and easy to try to give the shape of this emergence profile by designing it and milling it, and trying to play with the software to really push the soft tissue in the aspects that you need. So I really give like 2-3 times, sometimes 2 times, 3 times, changing the temporaries CAD/CAM until I reach to the final definitive restoration. But again, I've recently started using PMMA. Of course, that's a while ago, but the second set of temporaries, I start to go into more Emax or zirconium and leave it for a while. As I said, if I have enough time and the patient has enough time and allows for that. So definitely, yes, I'm using it for temporaries.
You use the on the Ritter case here. Do you use the peak multi-use, the peak scan body that also can be used as a temporary abutment?
Let me be frank with you. At that time, I mean, this case is like 3.5 years ago. So at that time, we didn't have it yet. You know that, and I had to use, since I have, I mean, the Sirona, the CEREC machine. They have on the library all the systems, and since Ritter is compatible with some systems, they have the tie bays and the scan bodies for these systems. So I used it. It's perfect. Everything's fine. Nowadays, of course, we have the scan bodies and the peak abutments and everything.
Well, that's awesome. I find that to be, at least for me, I think, and for Henry, that they made a peak scan abutment that you can also use as a provisional abutment, so you can keep it in the mouth, scan it, transfer the location of the implant, leave it on to do a pickup or reline of a temporary. Makes things, I think, very, very simple. I would like to thank you, Bassam, once again. Fantastic presentation from all of us here. We really enjoyed it. We always love to see you. Please stay healthy for us. Be well, and until the next time we see each other, be in touch with us. Stay in touch with us. We can't wait to see you soon.
Thank you very much, guys. Great honor again and pleasure. Thanks a lot. Keep safe, guys. Okay.
Thank you. All right, Mark.
So Hood, give me a sec here. Yeah, speaking of PET and dentin grinding, we actually sometimes incorporated that concept by taking the lingual aspect, grinding it down, and then grafting it back. So,
very much. It's a great honor and pleasure. Thanks a lot. Keep safe, guys. Thank you. All right, Mark.
so we'll wait till Alvaro is on.
Speaking of
Hello, Alvaro.
Yeah, I just have to get him to mute his phone. Yeah.
Well,
Are we good?
very excited. We have with us our next speaker, a very, very good friend from Colombia, now in Miami. Dr. Alvaro Ordonez has been a good friend for many years, one of my best fishing buddies. He's taken me out many times, put my life at risk sometimes because he's a real adventurer. He's an amazing free diver, can go down quite deep. I can just look at him from the surface. But best of all, he has incredible information to share with us, not only in everyday dentistry, but right now with this coronavirus issues and how it will affect our practices. I know that Alvaro will give us some ideas about what he's doing in his private practice about that as well. Alvaro, welcome, and thank you for being a part of this series of presentation. Thank you.
Real pleasure to be here. Thank you for the kind invitation, Henry. Can you see my screen right now?
Yes, you can put it on full screen.
Yeah, you need to put it on presentation mode.
Yeah.
Can you see it now?
Perfect.
Yes. Okay, perfect. So thank you again for this kind invitation. I put this topic together especially for you for this meeting. So it's the first time that I'm going to be presenting this specific topic. You know, as lectures get better as we go present them and adjust them. So please bear with me in that aspect. So let's talk a little bit about custom design of the guide cylinders. And how do we get to utilize all this information in our practices? We've been living challenging times. We have been trying to adapt to this type of situation during these challenging times. I've been doing my own contribution in my city and in my community, trying to treat some of these patients regardless of the coronavirus condition or not. So I have treated now several coronavirus positive patients. It's been a trip, you know, there's some adrenaline into doing that, so it gets to be fun, but you have to do it responsibly. There's no games to be played over here. It has to follow a strict protocol so we don't make the problem worse. I'm very thankful to all of you that made this presentation possible. And again, you know, today in a digital world, our dream, our desire is to be able to get to do it, you know, to get our hand wet into digital. And yes, we want to do it. We want to enhance our work, to excel into what we're doing. We want to strive for perfection. We want to do simple guides, print them in our office, or we want to do as complex as they can get. And it's very important to understand that this is a process of growth within our practices. We grow within the technology. We grow within the field, we grow within our profession. And the important thing is that as we are growing, we have to share this information with our colleagues. So we bring them along and they grow with us. So the important thing now is that the technology have got so good and so precise that we can treat any kind of cases of any degree of complexity in an environment that is fast and it's easy and it's simple. Now, we can get complicated cases and we can manage the cases if we follow step by step all the available technologies and biomaterials, including the ability to guide and get cases that can be devastating into just standard simplicity, a standard result that resemble nature in form and function. And we, of course, have to work with good people that can help us get better. This patient living in Dominican Republic, I haven't been able to get a good final picture because he keep on sending me the picture by his iPhone, but I'm extremely happy with the results. And again, producing guides can be as easy as you want or as complex as you want. It's very easy to get anterior, posterior, lateral control in the position as we are drilling through a guide. What is a little bit more complicated is to obtain good, precise vertical control to go into fully guided implant dentistry. And hopefully at the end of my lecture today, you're going to have a better understanding of what is involved into obtaining this type of precision as we are making our guides. So getting into fully guided, getting into vertical control can be a challenging topic. And that's the purpose of this lecture, to try to bring you into dealing with the challenges that are related to getting precise, good surgical guides. So, of course, we have to get familiar, and we have to get involved with the digital flow, and we need to understand the digital flow, and we need to understand which step is related to what, because one missed step is going to bring you into imprecision, and all the work is not going to be good, and we're going to get into eventually creating additional problems. So we need to learn how to go from A to Z, following 6 simple steps for computer guide fabrication. The first step would be to create excellent convincing images. And it's very important to separate the arches as we are creating these images. You can utilize a bite registration material like Regiseal, which would give you excellent stability, or you can simply utilize cotton rolls and trim them so you can increase the overbite by 1 millimeter, and that would give you the perfect separation for the mandible and the maxilla, so you can get to your plan and you can get to do what you need to do to get there. The second step would be to create an optical scan, and this optical scan or laser scan, as some people like to refer to, can be done with a stone model into a tabletop scan, or you can do it with an intraocular scanner today. And you're going to export this into the software. And of course, you have to make a proper selection of the software, a software that is the right software for you. The right software for me is not necessarily the right software for you. Today, we have a trend. We have been moving away from the interactive software, and we have been getting into utilizing integrated software. And there are several integrated softwares in the market today. Personally, for teaching purposes and even for simple performance in my practice, I have selected to work with Romexis, the Planmeca software, as my primary software because it's easy and it's a fast software. It has a simple digital flow, and in reality, it takes seconds pretty much to get the work done from the beginning to the end. All this technology is coming along with several new devices and gadgets, like the 4D jaw tracking machine that allows me to incorporate mandibular kinematics not only into my exam, but in the near future into the performance of several of my prosthetics and several of my T&J-related devices. So I'm going to be milling and printing devices that are going to have functional adjustment. And at the time of the delivery, probably the adjustment is going to be minimal. So these people are being very progressive. One of the big advantages also of working with technology is being able to incorporate high definition scanners to create high definition virtual patients, so we can engage the patient into the process of understanding, accepting a plan, so we can get eventually to perform our implant treatment or any type of prosthetic or surgical treatment that we might be doing. So all these devices put together a situation that makes our world better, makes communication with the patients better. And think about it. The type of work that we are doing is affecting the facial contours of our patient. So realistically, we can actually work with a patient in which we know in advance the dimensional changes that they are going to have as the result of our work. So if we create what it's called Acceptance appliance, and there's a beautiful article by Scott Gans on acceptance appliances several years ago. We're going to have a beautiful knowledge of what the patient is going to look like in their facial features. Then, of course, you sit down in the software and you make a process of planning for a guide or for prosthetic devices that you eventually want to print. And you need to also make the selection of a good printer. And again, a good printer for me might not be the same of a good printer by you. But thankfully, there are several kind of printers in the market. Anycubic, for example, is a Chinese company that creates a super cheap printer below $300 that if you set it up right, you're going to get precision prints. Or you can go as far as getting a Formlab printer, which is an elaborated printer, or a Corsair, or a Moonray, or even the beautiful Planmeca Creo, which is a super mega fast printer available today in the market. Regardless, what we want to obtain is precise, perfect fitting molds. Precise, perfect fitting molds that we can utilize and we can use to improve and excel our work in our practices. Then after you print, there's a post-processing work that involves an alcohol flush to remove the excesses of resin and extra curing of the devices. And you can go by hand, or you can actually have devices that are already prefabricated to cure and to flush that are going to work very well. And then you will need a guided kit. The guided kit have been evolving. There have been an evolution, and we have been moving away from these spoons in which we needed in the past an extra set of hands to be able to perform our guided surgery. And we have been progressively eliminating these spoons, moving into new systems. Ritter happens to be a progressive company that have been very, very involved with the development of the dental chair. They are basically the inventors of the dental chair as we know the dental chair today. And these people have been involved for several years in implant dentistry. They have created a fantastic guided system that have a burr integrated guiding barrel, which is the trend today. This beautiful system is interesting because it comes with two different types of drills, in which we have a narrow line barrel, which happens to be the narrowest barrel in the world today, specifically to work in tight spaces when we don't have enough mesial distal dimensions. This device is going to make it for you. Or we have the standard line for regular diameter and wide diameter implants. So these people have been designing smart systems now for several years, and they have taken it into implant dentistry. And there is also a new trend in implant dentistry for computer-guided surgery, which is related to working without the metallic sleeves. So they have taken that also into consideration because they believe in that concept, a concept created by the group of Dr. Maurice Salama, who is hosting this meeting today. I happen to believe in that trend. I believe that's the way to go today. We have been conducting some biomechanical testing on the impact of working with or without the metallic sleeves. A guided system is as good as your ability to set dimensions. The dimensions have to be precise. We have to respect these dimensions on the cylinder because the dimensions translate into precision. And these dimensions are not just related to the implant cylinders. They are also related to the pin, to the fixation devices for the guide system. So one has to be going along with the other because you don't want to be affecting mechanical structures. And talking about guide design, is very important to follow a process, again, a flow from A to Z, and everything starts with the optical scan being imported into a software that already have acquired a convincing image. With the systems that we have today, we know that the system let us know if we're having a good match or not. In the past, it was complicated. And then we have to do a transition because we are dealing with a software that is an integrated software. We have to transition to a different module, which is the implant module, where we do our planning process. We place our implants. We make sure that everything is fine and safe. And once we're happy, we go into the guide design module. And this guide design module has a platform which allows us to go step by step in a very auto-intuitive manner to create our guides. And the whole idea is to be able to create the space in which the metallic sleeves are going to fit, if you like working with metallic sleeves, or to create a good cylinder that will be able to guide the barrel integrated in the burr of the implant system, of the guidance system. So today, again, we have to choose between working with metal sleeves or no sleeves. It's a personal decision. Regardless, we have to go step by step. We have 7 steps into building that guide. The first one starts with setting the insertion direction of the guide. I always prefer to do it manually. Then we go into the process of drawing the guide and creating the boundaries of the guide. I like to extend myself 2 or 3 teeth away from the edentulous space. Then we get into the process of creating the parameters, and this software comes with some setup numbers, and these setup numbers are what confuse the people and are the reason of my lecture today, because we need to understand what they mean. And when they talk about thickness, we are talking about the thickness that the actual guide is going to have. They come in a preset of 2 millimeters. Then, personally, I don't utilize any gap to teeth because I have a very well-calibrated printer. So I set it up to 0, as you can see over here. And it comes also with a preset of 0.07 gap to sleeve, which I also set to 0 because I know my printer very well. It takes time to know a printer. It takes time to set a printer. For this specific setup, we are utilizing a 5 by 10 millimeter implant that we're planning for a surgery. And again, it comes with presets, as you can see over here, which I modify. So when we're talking about wall thickness of 2 millimeters or inner diameter, we are talking pretty much about dimensions that we need to adjust in reference to the system that we're utilizing. As I'm utilizing the Ritter system as an example today for my lecture, I understand that I might be working with the cylinder 3.4 for the narrow line or for the standard line with the 5.1 millimeter. I have to give that information to the software. So when we are talking about a wall thickness of 2 millimeter, we're talking about the thickness of the wall of that cylinder. When we're talking about an inner diameter, it's the inner diameter of this space over here, and it has to be adjusted depending on the barrel that is going to go through. So 4 millimeter is the preset. If I'm going to be using the 3.4 narrow line burr and barrel, that means I'm going to have to give an extra 0.2 or 0.3 millimeter to the diameter of the barrel. So if I have the 3.4 barrel, I'm going to have to get the inner diameter as probably 3.6. If I'm using the 5.1, I'm probably going to have to give it a 5.3. The height refers to the height of the guide cylinder from the most coronal part of the guide cylinder to the base of the guide cylinder. And the distance from implants would be the distance from the most coronal part of the implant to the base of that cylinder. Let's look at it in a different fashion. So what is what? Wall thickness would be related to the thickness of the material of the upcoming guide that I'm intending to fabricate. As you can see in both images over here and over here. The wall thickness could be 2 or could be whatever I want the wall thickness to be because it's fully adjustable. Then the inner diameter is this space, and the inner diameter depends on the barrel of the burr that I'm going to be utilizing on the system. If you're using a different system, let's say you're using the Cortex system, or let's say you are utilizing the Megagen system, you need to know the diameter of the barrel to be able to adjust it in the software. Then we are talking about the height, and the height would be the distance from the most coronal portion of the guide to the base of that guide's ring, that guide cylinder. So that would be what we would call the height. And then the distance from the implant would be the distance of the most apical part of this cylinder to the most coronal part of that implant. In the colors, you can identify easily what means what. Then you continue into the preview of your guide, which is automatic. With the press of a button, you remove the excessive material, and then you go through the process of adding some text, which I highly recommend because you can get some information in dimensions, etc. And you can even add bars to make your guide a little bit stronger. Once you send it into producing an STL and a PDF, you can move that file, that STL file, into the slicer software of the printer and print your guide. And once you print your guide, you go into working with your patients. This is a beautiful lady that lost one of her canines. And it's a simple process of now getting a guide that fits very well with very high precision and going through the process of utilizing this beautiful reader system, computer guided kit, and doing your surgery. It's just a matter of 2-3 burrs because it's a smart, simplified system. And you get to place your implant with high precision in a ridge that was extremely narrow, very hard to approach because it had an odd angulation, and you had to do no graft at all because you were able to maximize precision and minimize invasiveness during the surgical procedure. There is an additional, more complicated case of a gentleman traveling from Ecuador, who is about to lose some teeth because of a failing bridge and additional fracture. So we go through the process of planning. And the beautiful thing of this kit is that you can utilize it with any system that you have in your practice. If you are, for whatever reason, are not using this specific brand of implants, you can use any system at all, because basically all you have to do is plan and follow the dimension. And they have a system that will be compatible with most of the dimensions that you're going to find out there in the market. So we go through the process of doing the surgical procedure, the traumatic extraction, preparing the site, and doing additional sinus elevation, which we're going to do, doing an alternate utilization of summer osteotomes and burrs from the guided kit. Doing that process carefully and following all the indications, we get to elevate that sinus without doing any type of perforation, and we are ready to place implants. This happened to be zirconia ceramic implants in a 4.2 diameter and a 5.5 diameter. We add additional cortical and cancellous graft material to make sure that we fill in the spaces, the voids in the extraction site and the defects. And all we have to do then is place our implants, proceed to do our grafting as it should be, and our soft tissue management. I happen to be a big fanatic of this membrane. We do our periosteal dissection to close without any type of tension, and finish with a flipper with an ovoid pontic, which is going to have some gymnastic prosthetics as we go through. So we start creating and shaping the soft tissue to get a beautiful result at the end. You can see here that we have done the case and we have delivered our implants as planned, as we intended to do it, with an excellent Somers technique sinus elevation that was done progressively, alternated with the utilization of the guided burrs of this kit. The conclusions to finish my lecture is that you need to acquire precise images. Then with the precise images, you have to become familiar with the guide design, digital flow, and software utilization. Then you sit down and you do your plan carefully. Then you execute each and every one of the measures carefully, following protocol and indications of whatever manufacturer you are utilizing. My big recommendation, switch from the standard spoon systems that we were using 10 years ago into the new barrel systems, and Reader give you an excellent opportunity to get on the train, to get on board with the new trend of computer-guided surgery, so you can deliver implants that are going to be vertically fit in precision, and you're going to be able to fully guide them. And then if you do everything that I have told you and you utilize a printer that is precise and that you have been able now to calibrate the right way, you're going to smooth a beautiful and challenging surgical procedure. With this, I thank you for this tremendous opportunity, Maurice and Mark, Mr. Henry Salama, and all my friends over here. Thank you so much, and I hope that we're going to see each other in the future soon. Stay safe, friends. Thank you.
Alvaro, that was fantastic. Really, once again, each and every one of the speakers did exactly what we asked them to do, which was to stick to their and to provide the information in a very concise form. And I thought you that really well. It's not a big stretch for you, Alvaro. You seem to be very gifted, always have been with technology. As I've always said, to me, you are the most interesting man in the world, and you continue to be that. You're also an incredibly humble guy that's magnanimous. You share and you care about your fellow man, people in your community, fellow dentists, my own mother, who benefited from your incredible graciousness. So I want to thank from the bottom of our heart that you always provide your time for us and our community. So we really thank you very much for that.
Thanks so much. Thank you.
Listen, a couple of questions. One was from one of our experts that you know very well, Sylvia La Rosa, is out in Washington State. And she asked, what is your preferred radiolucent bite registration material? Said many companies have clear materials, and yet clinically they are still radiopaque radiographically as they are vinyl based.
Regisil. Regisil has an excellent material, and I've been using it for many years. So I recommend Regisil. However, most of the scans are done by the assistants, and they tend to just go ahead and trim the cotton roll because that's what it's easier for them, and they usually try to shortcut. But if it was up to me, I always tell them try to put by registration material because it's gonna reduce the shattering effect, which is a micro effect. We don't really know how much is it if creating an effect on the result of the volume of the scan. But I'm a believer that precision counts. So hopefully Regisil would be the right way to do and utilize silicone materials.
If you can give us a young dentist response that if you could give a cookbook, a summary, a cookbook of a young dentist that wants to be able to design and create and produce their own guides, surgical guides for surgery, what do they need? What is their armamentarium?
Okay, it's simple. It's really simple because today there are free softwares available. Like I happen to utilize Romexis a lot, but you have Blue Sky Bio, and Blue Sky Bio has YouTube tutorials that if you dissect them, you're gonna learn how to do it. I learned Blue Sky Bio by looking at YouTube tutorials. It takes time, but you get it. There's no excuse today not to digitalize because now you have a free software. Then if you have access to a cone beam CT, you have the volumetric image. Even the cone beam CT machines today, if you have a cast, you can even take an X-ray, a cone beam CT image of that cast, of that impression, and you can digitalize that with the same technology because you can convert the cast today into an optical scan. It converts that into an STL. So you don't even need an intraoral scanner. And I've done several surgeries utilizing a cast just to see the precision, and the precision is really good. You can't even tell the difference from the intraoral or the tabletop into that. So there's no excuse. You don't need pretty much to buy much. You don't even need to buy the scanner. You need to find somebody with a scanner to scan for you. And then you sit down and entering everything into the software. The Anycubic machine is the machine that I've been using in my courses, basically because it's small, it's compact, it's cheap. And if you trick it, if you set it up right, you're going to get high precision in which you could never tell that have been printed in a toy printer. And it's cheap. It's $200. It's $249. Even the cheapest photon is better than the expensive photon. So with $300, you are digital right away.
Excellent. And the last question, at least for me, is you mentioned, and specifically you were talking about barrel systems versus the classical keyless, sleeveless, spoonless. I mean, try to give just a small and a short, summary. Why is it so important to you, and certainly has been for me and our team? We also, as you know very well, with Marco in my office, we're producing our own guides and designing it all in-house, very much like you are in a similar fashion. Why have you jumped over to that same concept?
Well, think about it. The mouth is a very small space. So now you are getting a guide, which is being in place by friction, but you have to put usually 2 fingers to make sure that the guide it's not going to be wiggling or anything, because sometimes it does wiggle. Then if you are using one of these keys, which I like to call spoons, you need an additional hand holding the key and holding the spoon. Then you have your burr, and now you have 6 hands or 4 or 6 hands inside a mouse, with the transition into this barrel system, which, by the way, the team that Ritter put together, which is a multinational, multi-clinic, multi-talented team, was excellent. You know, they created a great product. They created a beautiful system in which they created duality. They created this barrel that fits directly into the guide with no necessity to add an extra metallic sleeve. So you are just going directly from the material of the printed guide. And you have a small barrel that you can get into a central lower incisor, or you have a wider one in case that you want to go into wider diameter implants in areas where there's more comfort because you have access. I know they are even adding a third component into this guided system for people that have limited opening. So this company is extremely progressive. We know that Germany have produced some of the best products in the world, and Germany, working with some of the brands in the United States, they are doing wonderful things. So in reality, I'm very, very impressed with the results of these guides, with the fact that they have decided to go into barrels, and not only into barrels, but into barrels that have science and academic results incorporated. The system that they have created into the burst to flush and pump saline solution into the surgical area is impressive. So I have to congratulate these people for the fantastic work that they are doing in their products.
And how about from a cost effectiveness? You know, people don't realize those spoons, those keys, they cost money, and the sleeves cost money. And then, have you ever got binding using the spoons and the sleeves and I mean, to me, I just think that it's too much cost, too many hands, and there's a high risk of getting the drill locked inside the sleeve. And I'm amazed that still so many companies still don't use this newer version.
Well, as I mentioned before, just as Darwin have a lot to do with the evolution of the species, I believe that Darwin have a lot to do with the evolution of biomaterials and the different devices that we're utilizing today. So this is Darwin, you know. We are evolving, we have to evolve, we have to adapt, we have to adjust, we have to implement, and we have to follow.
I couldn't agree with you more. And I think that that's exactly what's being done. The clinicians and the researchers at ground level, when the companies are listening, magical things happen, and you're certainly a big part of that and that evolution. And we can't thank you enough. Henry, Mark, any questions before we?
Yeah, just one question regarding the osteotomes that you used. You couldn't do that with your guide, so I'm assuming you removed your guides to do your sinus lift and then place the guides back.
No, I adjust through the guides. Several years ago, I went to CIDN Dental, and I spoke with them, and I requested that they would adjust the dimensions on the osteotomes. So basically, I'm building guides that will fit my set of CIDN osteotomes, and they have some stops that you can move up and down, so you have vertical control. So there's no way you're going to push into the sinus, because you adjust them specifically to work against the surgical guys. So all they have to do is call William or Bob or any of these guys at CIDN and request that they send you some of the same osteotomes that I'm using, and they will know what they are.
Okay, perfect.
Henry? All right. Listen, I just want to thank you once again, Alvaro. Thank you for taking your time out of your office.
I'm fishing every day. When are we going fishing?
I can't wait to come down there, but you know, if I come, I don't want to bring any black clouds.
That's okay. I can deal with it. We do what we do. We send Henry flying.
Exactly. That's it.
We miss you, and we thank you so much once again, Alvaro. Thanks so much, buddy.
All the best, buddy. All the best.
Good day, guys.
All right, Mark.
So we got Dean.
Oh, wow. Look at that sharp guy.
How you doing?
We got Robert.
Hi, Dean. Good to see you.
Good. Very good, you guys.
Dean, we're looking forward to having you with us, man. Really, thanks for taking time. You've been a busy guy. Busy.
Yeah, we've had over 7 Zoom meetings a week. It's been really crazy, but a lot of education out there, and happy to help everybody out there.
Well, I want some people to know that as they're waiting and they can hear us, the next speaker is Dean Vafiatis. He practices in New York City, if we don't already know. Dean is also a dear friend of ours for many years. He's a prosthodontist originally from Greece, but he's at the front line and all this craziness with this virus, and he has taken the time from all the things that are going on in terms of his family, his friends, the virus, his practice, his business, and all the things that are taking up so much of your time at home and many of you around the world. And I just want to thank Dean once again for being so gracious and spending this time with us and making himself available. So, Dean, thank you very, very much for that, and we look forward to your presentation.
Well, I always appreciate the invitation, DentalXP. You guys have been great for the last 10 years to us in New York, and we really appreciate it. All the doctors from New York love coming to the DentalXP meetings. For those of you who are suffering, some friends and family, we had a lot of people we lost. It's been a really tough time here in New York. A lot of our friends are still in the hospital. We're praying for them. So around the world, hopefully we get back to normal as fast as possible. Thank you again for allowing me to share these few moments with you. And the previous speakers seem to kind of touch upon all these things. So I'm just going to generalize and put everything in perspective for those of you who are not in digital. You can get a good perspective of how we do it every day. For those of you who are in digital, you'll get a couple of points of the things we've changed. I've been in digital dentistry since 2004 with CAD/CAM abutments back then, and we published on all that. But today, things have changed. Every 3 or 4 years, things change. So we're always on the cutting edge, trying to figure out new little toys, new things to make things easier. And obviously today it's a lot less expensive than it was. I think Dr. Alvaro alluded to that. I just want a big shout out to all the technicians involved. I can never thank them enough for all the great work that they do for us. And it's really been a symbiotic relationship with Ritter and all the technologists that have really helped us through the way. Again, going digital is really, at the end of the day, it's a better experience for the patient. Their chair time is really reduced to plan all these cases before the patient's in the chair, saving them hours and hours of time before coming to the dentist, and have everything really quality control. That's what we look at digital technology today. It's not only efficient and being really resourceful, but it's really quality control. And you'll see some of the things that we do behind the scenes that really allowed us to go to the try-in visit, but we're not trying things in. We actually know exactly where we're going. So prosthetically speaking, a lot of these full arch cases used to take us, 10, 20 visits to complete. And now all of a sudden it's down to 5 or 6 visits. So it's all has to do with quality control and planning things. And at the end of the day, for the staff, for the doctors, for the patients, it just makes things really easy for them to get from point A to point B, whether it's a single unit crown, for a single unit implant crown from start to finish. That timeline's gotten down to 40 minutes between 2 or 3 appointments. Again, it's being really efficient with the patient, so they're not spending hours and hours in the chair. So this looks like a lot, but we're going to talk about a little slide for each of one of them just to kind of give you a perspective of where we are today. 2 parts. Part 1 is the kind of the software, and part 2 is the design features of certain things. So, of course, digital acquisition. We are on the forefront of this. We bought 5 scanners back in 2010. We've just been testing them ever since. The different software is now available for the scanning. A lot of them are very inexpensive, less cumbersome, a lot easier to use. They all work really well. And we took it upon ourselves to do a lot of these tests. And I'll show you the last paper that's actually going to be coming out in about 2 months in the JPD, comparing all these different scanners. So they have different software, they have different touch screens, they have different things, but they all work. It has to do with one you feel comfortable with. I always tell people, go to the shows, sit down, play with them, push the buttons, try to figure out what really feels good in your hand. We know today, after doing this study, and Ritter was a big part of this, I can't thank them enough for the support for the last 5 years. between peak abutments, digital designs. Alvaro talked about the sleeves, the digital softwares that they've helped us develop behind the scenes. You know, nobody knows how hard it is to get a patent approved and get all these things happening, but they've been so helpful, and no red tape, you know, getting things done within 3 or 4 months. So we took our little accuracy of 4 digital scanners. This is going to be coming out probably in about 2 months. It's in press right now. And basically we found there was no statistical significance in any of the scanners. So you got to go out there today in 2020. There's no real difference in the scanning technology. The scanning technology is accurate. Now, if you see the mark down here, we'll talk about this a little bit later. The actual model that we created with the Ritter peak abutments, you can't see it from this perspective, but right down here, they're about 7 millimeters apart. And there was a lot of studies out there that you couldn't scan a full arch of implants because the tissue couldn't be scanned. There was tissue areas that couldn't be scanned, so the accuracy was off on the models. Well, we've come to figure out now with all the different tests that 7 millimeters is the key number. So 7 millimeters between each scan body is the key number. Once you're past that, there's a tissue component and the scanner can't pick it up. It wasn't that the scanners weren't accurate. It was that the pickup of the data after 7-8 millimeters was a defect in the tissue. So now we're developing our new patents coming out for a tissue marker, so you can scan any kind of tissue, even dentures eventually. That's going to change the way we do our scanning technology without the different. And then at the end of the day, you can have great technology in terms of scanning, but you have to have which printer is going to be able to make this accurate type of analysis from scanning to final product. And now it comes down to which printer you have. So of course, now we're testing all the different printers to see the accuracy is consistent throughout, and if there's a difference between a $5,000 scanner printer and a $20,000 or $100,000 printer. And again, Dr. Alvaro alluded to different types of different costs. You can get into this. We actually had one of the first printers up back in 2014. And then the evolution of the technology was so fast that we said, forget it. We went to our laboratory. They got the highest level of printers. So we got rid of all our printers. We sold them online. And we're down to one little printer, which is just for our foreign lab for our surgical guides. So all the different printers are now, printing different materials, milling different materials. We've been milling single units, like Dr. Rabi said. There are single units that he was making. We've been doing that for 15 years. And CEREC technology has always been great. So the materials are all there. In terms of smile simulation, you have DSD, you have 3-shape CEREC, different smile simulations that are really well in terms of planning your case, in terms of smile design. We went to these. I went to these courses. They're really helpful. I find these really valuable for education. When we do our course at NYU, we really just kind of do this for the education part of it. In the physical office, to do smile simulation is really hard. So we kind of change it over to Preview. It's not really expensive software. I can teach the staff how to do it. I can teach doctors how to do it. It takes pretty much 3 to 4 minutes to do a smile simulation instead of 35 or 40 minutes. So this is easy. It's an easy thing to do, especially for young dentists coming out of school. They can't afford a big software and a lot of lab bills and all that. This is a really easy smile simulation. And even for implants, we can easily say that even for implants, when we can do this smile simulation and then overlay, hold on, I'm getting a little fuzz in my, hold on one second. It's getting, sometimes they get a little click and the Zoom meetings stop playing. Let's go back again. Let's go here. Sorry about that. Does that come up now? Is that okay?
Yeah.
Okay, so you see the imaging. We could just overlay that with emerging files. We get our implant planning case really simple. Just to show the patient. At the consultation visit, this becomes a really powerful tool. In terms of diagnosing for implants, all these 3 speakers have beautiful digital designs of how they plan their cases. We've been using different softwares that I'll share with you. Right now, we're using the Remexis we used for many years, Dr. Alvaro. Now we're kind of switching over to ExoCAD and to InSequence. Has been very, very easy to work with Ritter implants. So the InSequence is what we're at now, and still using a little bit of the Remexis. But the ExoCAD is really cool. I'll show you what we do with that, and we're planning our software. This is emailed by the laboratory. So you can see here, I can look at all different views of this type of case that basically was an accident patient. So we can look at the prosthetics, we can look at the abutments underneath. We really can kind of do this on your iPad, on your phone. You can really look at these views and make sure you're in the right position before they go to the final design work. So this allows, again, quality control for us. It's easy to do. It's not, I have to log in and put passwords in. It's away from that kind of thing. So it really makes it streamlined. So for me, as a restorative dentist, when I get this stuff back from the laboratory, I want to have my sessions with my technicians that go really, really quickly. I don't have to spend a lot of time. If you have 2 or 3 cases you have to go through, you don't have 2 or 3 hours to do that. So I want to be able to go on my computer or go on my iPad, iPhone, take a look at the scan, take a look at the design work. You can click on and click off the different positions. So this is it's an easy way to go. It's not expensive. It doesn't cost anything. So that's why I like it, because it's easy to teach and easy to use. In terms of impressioning, we know that all the impressions work. Again, remember that digital technology does not replace fundamental prosthodontic principles. You got to understand teeth. You have to understand tissue. You have to understand bone. The technology just helps you kind of do it fast and helps you, become a better diagnostician and have better quality control. But we can do full arches with teeth and with implants. We get these designs back from our laboratory that are pretty accurate. We can prepare the teeth, obviously, take our scan, deliver nice high quality. These are all pressed, by the way. These are all milled and pressed, very inexpensive to do. Again, we've been publishing on that since 2004, 2011 with our first ceramic in-office veneers. So these are really easy to do. You can see a little staining and glazing on this, but these are all pressed. These are all milled Emax units. And back here we have our 3 implants and our 2 implants, changing the vertical of this patient. In terms of full arch scanning, Ritter was one of the first ones to give us our scan bodies back about 8 years ago. And you can see the definition of it, very clean, very easy to put on. And now here comes the part where we're going to use, this is the most important part, is actually designing this with the laboratory one-on-one to be able to put our provisional scan. Here's the purple, make sure our abutments are lined up. You can see these are not lined up. We got to move them over. Occlusal views, we have to move things over to make them work. This allows us to see our provisional, which is in the wrong spot, and the actual design, which is in the right spot. So again, planning these things behind the scenes. So when we go to the patient, we're not kind of trying it in and losing appointments and losing time and losing a patient's time in the chair. We want to get in there, be very efficient. We know exactly where we're going. And then we can go from the scan to the digital design, to the provisional, to the final. In this case, it's a 5-visit case. It's scanning. I'm talking about prosthetically. Scanning, try in abutments, try in your copings, pick up impression, visualize the final on the 4th visit, and delivery on the 5 visits. So a full arch, we're not talking about immediate cases, we're talking about delayed cases, become very, very valuable in terms of the digital design software behind the scenes. In terms of abutment design, single units, again, these are the great peak abutments, and we talked about that. I think it was Dr. Robbie talked, Dr. Richard also talked about the actual emergence profile of this, and we'll show you how we use that to really create a great abutment. And the real problem with posterior teeth, obviously, is the food impaction issue. And we can avoid this. This is not the way we want to plan our cases with all these spaces. We want to be able to change the food impaction. And a lot of it has to do with changing the environment, recontouring the teeth, changing the emergence angle, which has to do with the actual design person who actually is designing it, and then showing it to us to actually look at it and quality control that. We had published a formula back 2014, 6 years ago, and it was on a digital platform, but most people were doing analog back then. Well, now everybody's doing digital, so now actually the formula becomes much more valuable because everything's digitized. So we could scallop the tissue. So this is a regular healing cap that you could put on, or you can use these peak abutments with a little bit of composite and actually scallop the tissue at stage 1 if it's a flapless case, and you're basically making a customized healing abutment. We also published on this regarding the anteriors, where we can actually make a crown root form, which costs about $65 and gives you a really good anatomical position at stage 1 if you're doing immediate cases, especially on the anterior. And again, Dr. Ravi talked about that when he was designing his scalloping software to be able to do that. But you can actually order that from the laboratory very inexpensively and get these beautiful customized healing abutments. This is where we're going pretty much 80% of the time. And that allows us with this formula here. And if you need these articles, I can email them to you, drdean17@gmail.com, and I can send you these articles. But they really help the designer when they're doing the design work. Another piece of the puzzle is the radiograph, right? If you have the radiograph, then you kind of know how much you can actually build out the abutment. Without the radio, it becomes sort of a guesswork for the designer. And using the formula of the X value, we can figure out the change in the tissue, which is called the change in Z formula, which basically tells you as the anatomic position comes out of the abutment, the tissue kind of moves down. And that's why we saw some recession in our cases in the early years when we were doing prefab abutments. So we want to avoid that kind of abutment. We want to really create this closing type of angle so we can really close these emergence profile and close that position there and give us just good tissue contour and good anatomy for our CAD/CAM abutments. Here's another example of that. Here are the Ritter analogs. And again, you see this is a 7 millimeter position specifically done for that so we can get great accuracy. And again, the part with the three-dimensional designer, remember, if the designer doesn't understand tissue and biology, they're going to give us something that may not really work. And we try to put it in and it doesn't fit, or the tissue collapses, or it's not really different. So each part of the tooth, each side of the tooth has to be designed specifically for that case. So by looking at the formula, by looking at the tissue biotype, by looking at the radiograph, the designer has a better view. So we kind of tell our designers, hey, listen, take a look at all the variables. Don't just look at the screen, pull up a number, and try to design an abutment. Let's be really specific about it in the nuances of each kind of abutment with each part of the tooth, because that really changes. So you can see here posteriorly, these two units are SLA model created with Emax, but you can see it's kind of supporting the Emax crown, the access hole. If you're doing cementable, by the way, we want to make sure you take this photograph. If we're doing cementable and we have to get to that screw, we want to know where that access hole is. A lot of times dentists are putting these cementable cases on, but they don't know where the access hole is. If they need to get the screw out, it becomes a nightmare. So by taking this photograph, we can see that we have a tight tissue. There's not going to be any cement going back into the implant. Because we've moved the margin away from the implant, we're actually 5-6 millimeters away from the implant. So even if there's excess cement, it's not going to go down to the implant and really cause that peri-implantitis. Even on a sloppy situation, it won't. Now, what we do here on these guys, if you really want to be careful, right around the margin here, we'll put a little floss in there, cement the case, take out the floss. We pretty much ensure that we're not going to have any cement going down the area. And here's the occlusion part of this. Again, I want to just really emphasize in terms of occlusion that occlusion on the posterior teeth have got to be in the right position. It's got to be really in the right centric position. You can't have it coming out on the posterior implants because otherwise you don't have support for your mandible. So we want to emphasize our occlusion on those posteriors are really critical. In terms of the OVD, the restoration of the vertical dimension, the TM joint becomes really valuable. And now with these new CT scans, we just got a new R2 gate CT from Ray America. I'll show you what it looks like, but the quality of these joints are so incredible. It's a facial scan, it's a digital scan, it's a model scan, it's a 16-second 20 by 20 CBCT scan, super powerful, a little expensive, but definitely worth the time that I'm saving. Again, you can actually scan the denture, you can scan the model, and then puts everything in together literally in 2 clicks. You're converting all the STLs into the CT scan. It's super fast. Here's one little case we did with InSequence. Again, the working digital model from the working OVD, the design work, the final design work. Again, everything's planned, but occlusally, I want to make a point here. The occlusal vertical dimension has been planned from the joint perspective. The joint has to be in the right position. Once these are dentalist patients or even dentate patients, the joint's in the wrong position. We want to really capture that and then make our plan with a great position. And what's great about the InSequence, what I love about this is not only is a surgical guide and the bone reduction guide, but it actually gives you all the steps listed here in a little kit. It's very cost effective, but this is the most important part for me is the final OVD, CEJ to CEJ is measured. It's accurate. You plug it in, the patient closes in that spot, and then you lock in your prosthetics. And this is the day of surgery. This is a post-op 3 weeks. So the vertical dimension is really what the key component is. And it allows you to get this virtual patient from starting photography to scan, CT scan, planning, and getting the person in the right position vertically so the teeth are in the right spot. Again, some really good accuracy here. You can see her cant in her maxillary position. You can see every piece of her cervical spine, which is connected to the joint and the breathing apparatus. You have all these cephalometric x-rays. We have an FMR actually angle here, which is a Frankfurt meets the restorative angle. And we use that a lot for our vertical dimensions cases like this, where you can go here. You can look at the CT scan posterior here, and now it's in the right spot. So that allows us a nice vertical position for her restoration. Again, another one here. It's posterior here, and now it's more anterior to restore the vertical. For breathing, it becomes another great tool. Look at the accuracy of these sinuses lifts. The sinuses for sinus lifts. And the airway passage and beautiful color view of breathing apparatus for those people who are doing sleep apnea. So the technology is super fast and super clean. In terms of photography, of course, we want our digital cameras communicating, but now with our iPad, we can actually take our photograph with different light sources. You can use these kind of different light sources. You can buy them online. But one of the cool things, obviously, is the videos with our photograph and our light panels to give us a good view of the patient. So I find this easier to use these than actual facial scanners. The videos of these are very, very accurate. And then finally, when we take our pictures now, we have a Wi-Fi camera. When we take that photograph digitally, it comes right up on the screen. The patient can view it immediately. It's on the server now. I go ahead to my iPad. I pick up my iPad, and now I can discuss things with the patient because it's on the server now. It's all connected. We push on the iPad, and there's the screen that I just took. So it's really valuable in terms of patient communication to allow the patient to kind of take a look at provision, take a look at their case, take a look at whatever you're trying to explain to them, but it becomes really super powerful. This is what we use every day. Again, if you need a picture of this or you need the whole PDF of today's program, you can email me at drdean17@gmail.com. Thank you, Canadian Implant Dentistry. I was so happy to be part of that. I was born in actual Montreal, so I am Canadian. I am a U.S. citizen. So thank you for allowing me to help with your program. And, I appreciate the time. DentalXP, I always love you guys. And Ritter Company has just been amazing. So thank you, everybody, for all your help. I hope this helps.
Yeah, thanks for being here
today. Thank you so much. It's a fantastic presentation. It's amazing how much information you can impart. Somebody so disciplined the way you are, and really an amazing amount of information. And it was a great presentation. So thank you.
It's like a little teaser, right? It's a little teaser to come. Things to
yeah,
come.
But there's actually a lot more than that, because there's actually some very, very good information that's well organized, and you can get a lot out of it. One of the questions that I have in front of me was that it's very obvious that you have the documentation is very important clinically, not only at the time that gives you immediate feedback, but down the line, like taking a photograph of where your screw access is. I think is really a brilliant thing to put in a patient's chart. If the abutment screw comes loose, you want to be able to access it. You're not going to destroy the crown in order to do that. In some ways, you actually will alter it into a screw retained restoration.
Exactly.
So that's one thing. You showed a lot of ways of verifying that an occlusal vertical dimension is actually beneficial to the condyle position, airway space, and so forth. But when you are altering occlusal vertical dimension, what are the variables that you're going to use before you decide that that endpoint in your provisional is actually acceptable, and you then go ahead and take it to the final restoration?
So there's three things that come into play for occlusal vertical dimension. The first is the starting point. So the first actual x-ray that's done is with a closed position, chin position, with nothing between the teeth. Alvaro was showing the separation so he can plan his case. But we want to have no position when we start. The second position would be facial aesthetically. So the second answer is the facial aesthetic position of where we want the teeth. If the person actually has teeth, we can use them. If the person has no teeth, we need to make some kind of a denture prosthesis in the right spot to look at it visually and make sure at that point, we'll take another x-ray of the radiograph, that the joints are in that zero lock position. Many times what I'm seeing online and people putting in immediates, they're in a collapsed vertical, the teeth are coming this way, they're not really measuring that. And it's a big part of what people are showing, but not really showing how they actually take it. So we take our pre-op photo of our CT scan to make sure where the joint was, and then make sure where the joint is, and then we're locking that into position and we're translating that to the laboratory. That's a big piece of information.
How about phonetics, patient comfort, those kind of issues? Does that come into play?
Well, remember, the patient comfort, you got to think of it this way. They're collapsed, and if we're restoring them, we're not taking good people with good joints and making them larger, right? We're taking people that have been collapsed joints, putting them in a zero position. And what happens with in terms of health, in terms of relaxing, it's like a bite plate, right? You put people in bite plates to relax their muscles and kind of loosen things up. So we're not stretching the muscles to the point where people are in pain. We're putting them back to where they actually lost. So understanding the lost vertical dimension and then getting them to the restored vertical dimension, and you look at the joints, how they compare, and it's really, really easy to look at before and after and say, this is the right position. And it's like a bite plate positions because they're just relaxed and the muscles are free and the patient's moving left and right in a nice guided position.
Well, you can see that this is just a small conversation. I know you have a whole year program in reconstruction, and I'm sure that's a big part of the discussions. But thank you so much again for for all these pearls. Really appreciate it. And always great to see you, Dean. Stay safe, my friend.
Thank you, guys. Thank you so much.
Fantastic. Okay. So we have Dr. Richard Myron, who's our last speaker for today. And I've known Rick since undergraduate and at Western University. So it's dates back to 2004 that I've known this guy. He's gone into the research path. I've gone into more of a clinical aspect in dentistry. And he's published over 200 articles. He's written 4 textbooks. He spent the last 7 years in Switzerland working with some of the top researchers in implant dentistry. And his main focus is on implant dentistry and biomaterial research. And now he resides in Florida, but he's still a Canadian at heart. So I'll introduce Rick and let him take it over now.
Perfect. I want to thank, first of all, both CIDN as well as DentalXP World for having me here. It's a great honor. I've watched a lot of the videos on XP. I've learned a lot today, even from a lot of the writer research and ongoing. I fit very nicely into this implant field. Like I said, most of the major implant companies in the world are located in Switzerland, and I ended up residing there and doing a lot of work. I'm going to talk about a topic that I think is very interesting for clinicians, because a lot of people forget how important overall systemic health is for implants and when they integrate. So I resided, like Mark said, in Switzerland. I owe a lot of credit to these clinicians. I know Dr. Boozer, who was one of my PhD supervisors, spent some time with XP at one of their symposiums. Preclinical research is what I kind of focus on. We develop biomaterials, we develop implants, and I do a lot of this work with Dieter Bossart here, who's the head histologist for Dr. Boozer, as well as Reinhard Gruber, who is head of cell biology. And some of the work that we do is really focused on, how are these biomaterials integrating? Always remember that if you place an implant into your body, it's not just a happy medium where, bone cells come in and make bone. It's really immune cells. And if your immune cell system is a little bit off, that implant might not integrate perfectly. And it explains exactly why, sometimes clinicians will place an implant and you're like, that was a slam dunk case. Everything looks great. And then all of a sudden 6 weeks go by and it's a spinner. It's coming out of the body. And you're like, what the heck happened? There was a lot of bone. Everything looked great. And a lot of that has to do with the immune system. And I'm going to, just kind of go over the story behind it and then how you can optimize it for your patients with vitamin D. One of my supervisors was Dr. Brunette and Dr. Hamilton. And he was one of the first guys in the world to show that actually implants are actually preceded by macrophage accumulation. So he's one of the first guys to show that it's not bone that's just going on an implant and making bone. It's really your immune cells that are coming on the implant surface. And then they say, do I like the material? Do I not like the material? And then is it going to be integrated or is it going to be rejected? And he's won many, many awards for some of the work that he's done there. We have done some work in Bern, Switzerland. So this is, out in Bern, we were looking at these immune cells. And long story short, I'm not going to get into all the details, but, your immune system can be very inflammatory or it can be very happy. And in science terms, we call this M1 macrophages, which means that they're more inflammatory, or M2, which means that they're happy. And these cells are very plastic, which means that they can be back and forth very quickly. And that's why you can have periimplantitis and everything starts getting destructed. Or, you can have a happy situation, which is M2, and then you can start making some bone. And so Dieter and I wrote this really nice article. It was called Osteomax, and it stands for osteomacrophages, key players around bone biomaterials. And we wrote this at the same time that we were in the process of developing new implant systems. So as you guys know, we worked a lot with Straumann, with Nobel, which are both in Switzerland, as well as all of their zirconia companies. So when you look at Z Systems, Xeramax, they're all built in Switzerland, and we were in the process of developing these materials. And as, Dr. Boozer and his team were implanting them in animal models and we were getting the histology, we always saw these immune cells trying to figure out what are they doing, why are they there? And then how do you optimize them in order to get more of these implants to integrate properly? And so that was some of the work that we were focused on. And you'll see Brainmark's group and a lot of the older guys that were part of his team, Albertson, Weinenberg, and a lot of the guys came up with this concept about how these immune cells basically dictate peri-implant destruction, peri-implant regeneration, and what's going on here. I read this article, and I worked actually in Michigan with Homley Wang and Dr. Ginobili for a little while. And one of my, co-residents, he was more like my classmate. We spent a lot of time together. He wrote this article with Dennis Tarnow, Homley Wang, and Will Ginobili. And as everybody knows, these are big names in the implant world. And it had to do with is metal particle release associated with peri-implant bone destruction. And really, the whole concept here was these implants are getting integrated. Sometimes we have problems. These titanium particles are being released. What's going on here? And so he was doing a lot of research in this field here. And as we know in the perio field, many, many years ago when we talked about periodontal disease, it's very linked with many, many systemic diseases, right? So 30 years ago, if you were to say perio is involved with all of these different things as a dentist, you would have been considered like what's going on. Today, it's very well known. Perio is linked to Alzheimer's, diabetes, rheumatoid arthritis. And when you look at all these connections, this is the same thing. It's just inflammation is occurring in your body. And over time, what's happening is that whether that inflammation comes from diabetes, whether that inflammation comes from periodontal disease, it all links to your immune system. And when this immune system gets a little bit dysregulated, then you're going to have some problems with, many, many problems in your body, as well as with biomaterial integration, whether that be implants or bone grafts. So I wrote this article here, and it was an interesting one for our group. I was living in Michigan, and we called it Basis of Bone Metabolisms Around Dental Implants. So I was working in Michigan. I was hanging out a lot with Homley Wang and Alberto and a couple students. We wrote this paper back in 2016, and we talked about the importance of, low vitamin D levels. And again, we talked about these immune cells being discussed as being key regulators and how they're crucial for, implant integration. And I was shocked because, we were doing so much cool research on platelet-rich fibrin, on Emdogain, Osteogain, a lot of implant stuff with Boozer. And out of all those papers, I got an email one day and it said, congratulations, this article on basis of bone metabolism is one of the top 20 most downloaded papers in recent publication history between the year July 2016 and June 2018. And I was scratching my head. I said, out of everything that I'm working on with all these guys, this immune cell stuff is the one that's being most downloaded. And it's one of our group's most cited papers. And I was shocked. And it comes down to the fact that, especially in Europe, when I was living in Switzerland, people started to become more and more aware of, vitamin D. How important is it? How do we optimize immune cells for these implants to integrate? Okay. And it's very obvious. You don't think about it, but vitamin D is obviously a vitamin for bone. None of us are dummies. We all know that if you have osteoporosis, the first thing your doctor is going to say is take vitamin D, take vitamin K. But meanwhile, we're all implant surgeons. We're placing implants in bone all day long. And the main vitamin for bone is vitamin D. And most of the population is deficient. And people don't make the link of how important that is for these implants to actually integrate. So now today, there's many links like in perio disease with Alzheimer's and diabetes. The same links exist with vitamin D. And again, it's the exact same thing. When that immune system gets a little bit off-regulated, you start to have all of these problems systemically. And so when we look at the literature on vitamin D, and I'm going to go through this rather quickly here because obviously it's a short lecture, but in 2009, this group of researchers use these animal models where they place these implants and then they do what they call pull-out tests. So they actually try and yank these implants out. And the animals that were vitamin D deficient had a 66% reduction in the strength of these implants. So they weren't integrating properly. Okay, only 33% of the strength. And then some years later in 2012, here's another image of Reinhard Gruber. So he was head of histology and head of cell culture. He found that with these animals, if they were supplemented, you can re-get them to have good bone implant contact. Okay. Then you start to see some papers that were coming out, 2014, vitamin D suspected as a causative factor for immediate implants. Joseph Shakrun wrote a nice article on 2 neglected risk factors a couple years later on cholesterol, high cholesterol, low vitamin D levels. So he published a nice article there. And again, the same guy that published the article with Dennis Tarnow and with Homley Wang and with William Ginobili, was publishing again on vitamin D deficiency in early implant failures. And this colleague of mine lives in Germany. I was in Switzerland. And it's the same thing. We're working in these schools. We're these science guys trying to figure out what's going on. These clinicians are placing these implants and then they're failing. And you don't know why they're failing. And at the time we thought, well, maybe they're allergic to the implants, something's going on. And again, you send them to get lab work, across the street at the hospital. And every single time they came back vitamin D deficient. Okay, so a lot of research in this space. This right here was probably one of the most well-known studies on this topic. And the reason why is it incorporated 2,000 implants in 1,000 patients. So, this work here, like I said, is very, very well recognized today. Overall, we know that there's implant failure rate is 4%. Okay. Smoking, if you have heavy smokers defined as 15 cigarettes per day or more, 6% failure rate of these implants. So it goes up from 4% to 6%, 50% increase. Okay. Generalized perio, we know that that's a risk factor as well, 6%. Look at vitamin D deficiency here, 11%. Okay. So the study is actually from thousands of implants show that actually implant failure rate is going to be higher if the patient's vitamin D deficient than if they're smokers or if they have generalized perio. And across the country, especially in the United States, I am sure that most people get patients to sign informed consent if they're smoking 15 cigarettes a day. But very few people are actually doing something about these people that have vitamin D deficiencies. And that's one of the reasons why that paper was so, widely read and highly cited, the one that I wrote in 2016. We see today with coronavirus, of course, one of the things that you see a lot of is the CDC says, well, take a lot of vitamin D right now, boost your immune cell health, right? Take a lot of vitamin D. And that's the recommendation. And it's funny that I started reading these because, in the implant world specifically, very, very, very important as well. Now, every country is very different. So I live in the United States, and I'm just going to go very quickly over the recommendations. If anybody wants any of these papers, like I said, I'm more than happy to send them to people. In the United States, of course, the endocrinologists give the recommendations for what to do with deficiencies. Okay, so it's very straightforward. They have everything laid out depending on your age, weight, etc. Typically, what you give patients is 5,000 units per day for 12 weeks. Okay, so if you're going to a normal medical doctor, that's the recommendations that they give you. And I remember thinking, 12 weeks, if I got to place an implant, 12 weeks is a really long time to wait. Is there any way that you can, speed this up? And that's where we've done research over the years to try and get patients to get up to speed a little bit faster. Now, this was something that was cool that was available in Europe for our group. So we started using this many years ago, only recently brought to market here in the United States. You can test vitamin D deficiency from a single finger prick. So exactly like you can get a glucose reading in a few seconds, you can get a vitamin D check from a simple blood draw. Okay, you can do it in office. It takes about 10 minutes. I'm going to go through this video very, very quickly here. The way it works, this was provided by Dr. Paz, and I'll show you some of the work that they've been doing in the White Clinic. But you take a drop of blood, you mix it with this buffer. It looks very similar actually to the coronavirus test today. It's the exact same concept. You put the drop of blood there, you put this little reader over top of it, you wait 15 minutes in this case here. And then at the end of this 15 minutes, and I apologize for going through this video very quickly, but it gives you a reading. Okay. Now I have a reading. Now I know this patient is in the optimal level, so I'm comfortable placing the implant, or, I'm hands back. We got a supplement for this patient. Okay. Very easy way to do it. Now, as well, antioxidants are very important. Give a lot of credit here to people that have done a lot of research in this field. Pat Allen, very well-known periodontist, did a lot of work in this field. Not the topic that I'm going to discuss here, but of course, very, very relevant for, general perio health, general health in general. And Pat, like I said, Alan's done a lot of great work with, antioxidants. They're used for perio disease. Dr. Ian Chappell, located in UK, has done a lot of work. And, if you want to prevent periodontal disease, if your immune system is off, you definitely need, again, this is from 2011, sufficient antioxidants, vitamin D, calcium. These are all things that are required for general health. As I've been getting involved more and more in the research, I started going to the conferences of nutrition to learn more. And my only goal was, look, I want to research with endocrinologists to figure out, what do I do for my patients? Because a lot of them are vitamin D deficient. How do I get them to the right level so that when I place my implant, it's less likely to fail? It was a very simple goal. And I started going to their headquarters, and, they have these massive labs and, all the research that they're doing there. It's not a space that I do a lot of research in. I was just, guys, get me something that I can use that's going to be very effective for patients. Okay. And long story short, I learned about this company, been around for 20 years. It was called Vitamedica. And it was made for medical doctors and specifically plastic surgeons. And if you go to a plastic surgeon's office, which I've done a lot of because I've done a lot of work with platelet-rich fibrin, and they wanted to learn Pure F, so I'd go to their offices, teach them some stuff. And everywhere I went, they'd have this supplement, Vitamedica, and I'd ask them, what is that? And they say, well, Rick, we would never go into surgery and do an elective procedure like a nose job, a boob job, a facelift. We never do any of these things, knowing that the majority of the population is deficient in a lot of these important antioxidants, minerals, etc. So we force patients before we go into surgery. We always take these supplements and then we go do our elective procedures. So well, that's kind of smart. It's not expensive, $98, and made in the United States and California. And it's been around for 20 years. So like I said, that was the first kind of, the seeing this and being applied in medical space and wondering why we weren't doing that in dentistry. And I remember seeing this figure. It was back in 2016, and it was presented again at one of these nutritional conferences. In the United States, it's never happened before, but every single year, life expectancy actually goes down in the United States. And we're the only country in the world where that happens. Okay, most countries, life expectancy is always going up. It was always the case. And in the United States, life expectancy is actually going down. So if you have a little kid that's born today, he's less likely to live as long as you are. And the reason why is because poor nutrition, people are more stressed, and they give you reasons, heart disease, cancers, etc. But the reality is, it becomes a little bit scary because in the US population, many of these people, because of poor nutrition, because of eating at McDonald's and Burger King and all these places, you see a lot of deficiency across the population. And when you look at this list, you see right in the middle there, vitamin D deficiency, 70%. And that's the vitamin for bone. And we're playing in bone all day long as implantologists, right? So, that's where we were starting to make the link. Now, the problem with Vitamedica is it didn't have vitamin D. Okay, so with the nutritionists, very early down at the university, we started saying, okay, let's put Vitamedica, because it's got all the packages for antioxidants, give them vitamin D, whatever you guys recommend, and then vitamin K, which is important. And then I said, how can I speed this up from 12 weeks to get it down to 3-4 weeks? And that's where, it was important to incorporate boron and manganese and all these other, different types of supplements. And when the package was figured out, they put it all into one supplement and they called it Dentamedica. Okay, so that's how that was created. And this is just a pre-implant program for patients that are deficient in vitamin D. Okay. At the same time, at the University of Utah, they developed this scanner where you could actually measure antioxidant levels right from your hand. Okay, so it's an easy way that this light shines on your hand and it gives you a reading. So now we had something that could test antioxidants very easily, as well as with a finger prick, you could test with a blood drop what the vitamin D levels were. So it's very non-invasive, and we got all the data and we started running some of these studies. So when you look at the general population, we've learned some things that were quite interesting. First thing that I can tell you, smoking out of everything is by far the worst thing for antioxidant levels, okay? The people that were smoking, like I said, their general health, even if you had a young female come in that was a smoker, the scores extremely low. Smoking was by far the worst thing, much worse than obesity even. So even these people that had 35% body fat index, not nearly as bad. And of course, the more nutrition more fruits and vegetables you ate, the better, and that's just obvious. But the reality is most people were not eating to have high levels. Then we could give people supplements. Okay. And that's when we started in research, 1 pack per day, 2 packs per day, trying to figure out, how to get these people up to the right levels. Okay. Long story short, like I said, there's a morning and evening formula package that comes with this. And when we finished it and did all the research, one thing that was cool was that McGill Stanley was one of these guys that was kind of always, leading edge into digital dentistry and, next generation type clinic. And they were really into using more zirconia and going more holistic and different things. And this was something that in the zirconia world, people were coming in contact with a lot of these vitamin D and how important it is. So with Dr. Anna Paz here and his group, they did one of the first research projects on this topic. And in the study, the way that we designed it, we said, okay, let's test 2 different systems where you can measure vitamin D very easily. Okay, finger prick tests. Okay, there's one, rapid D, and here's another one. And then compare it to normal blood work. And at the same time, I had my scanner at the university. I sent it off to their group in Lisbon. And I said, you guys use a scanner. You guys take all the measurements, okay? And for those that want to know, the first thing that they did was they compared across a big population of people. This is in blue here, the lab score. So this is, you're getting a vitamin D check. You go to the lab, you get a check. Here are the 2 systems here. And that's just a finger prick, just to figure out if the thing's accurate. And you can see across all of these, people, it's very, very similar to the actual blood labs. And then they followed the general recommendations that are given, the 6-week program. So it's 4 weeks before surgery. You give the supplements 2 weeks afterwards. And sure enough, when you look at the data, this is all before surgery. This is all after they've taken this 4 weeks, 6 weeks of supplements. First things first, even in Lisbon, which is a sunny country, 82% of the population was deficient in vitamin D, okay, much like in the United States. And then, of course, after they take this, then everybody goes up in value, okay, and they all go into the right ranges. So it's a very, very easy thing to do, and it's highly recommended. The least thing that you should do is recommend all your patients where you're placing implants, say, take 5,000 units of vitamin D at the bare minimum. These little Dentamedica supplements are designed just to optimize things a little bit further, as well as the antioxidant scores they did. And again, 35% of the population here is deficient. And this is just a way that you're a surgeon, you want to maximize your chances of having as much success you can for your implants. So why would you ever place an implant into somebody that's vitamin D deficient when you know that that's 3 times higher failure rate, right? And so that's how, these programs came about. Last 2-3 slides here. Scott Froome has written a very nice article very recently, February 2020, on vitamin D deficiency and its impact on wound healing and implant failure. So you can see a lot more colleagues are starting to get more aware of this concept. So that was a really nice article that was written straightforward. Our group with some of our guys, so Dr. Pico, somebody that I work very, very closely with, as well as Dr. Bashara, so Mark, we wrote an article published in Dentistry Today because it's becoming more and more of an important topic, especially in the United States, because a lot of people are eating worse quality food here. And it was just titled Vitamin D Deficiency and Early Implant Failure, What Every Clinician Should Know. Okay, and it just had to do, let's show you guys the test that can be done very easily in your office. Let's show you guys supplements. Let's show you guys what range of vitamin D you should be in, just so that clinicians are a little bit more aware of it. And it's to prevent people, such as this case here, which was provided actually by Mark. You see these cases where, good bone, good width, bleeding, implants go in, everything looks great. And then all of a sudden, 1 month later, you look at this thing and a bomb went off, right? Implants failed. You're asking yourself, what the heck happened? And a lot of this is just related to, again, the immune system, okay? And so I just gave this very quick presentation. Never forget how important your immune cell health is in this field. And of course, I want to thank a lot of the guys that have done work in this space, and I'll take a few questions here.
So fantastic presentation, Rick. So would you recommend for every single patient to get tested, or would you put them on these supplementation programs in either circumstance as a prophylactic?
It's a very important point. So ideally, in a perfect world, you'd want to test everybody, okay? You'd want to test everybody. It's a 10-minute test. But the reality, like you said, is a lot of people are not going to go through that, entire length. I watched a video of, Miguel Stanley on Sunday and talking more about slow dentistry and his concept. In a perfect world, I agree fully with him and just doing everything right. But when you're working in the United States, people they got, bodies to move, you got to do your dental procedures and all these things. And so a lot of clinics, what they say is, a lot of the population is deficient. I don't want that risk of placing an implant into somebody that's deficient, and they just give every single person the supplements exactly as they do in a plastic surgery office, which isn't a bad idea.
Richard, thank you so much. Wonderful presentation, bringing in this angle to it. We've tried very hard when we put together this program to really include all aspects of dentistry. We started out with soft tissue. We were into full arch cases, single unit, immediate extractions, the digital component of planning and executing, as well, of course, as a restorative and full arch, but this component of actually looking at the immune system, looking at how our patients on a molecular level are ready to actually receive all this treatment is certainly is part of a very, very important aspect of therapy as a whole. So thanks again, Richard. Wonderful presentation, a lot of great information. Appreciate it.
Yep.
So thanks, Rick,
to
again.
end this online symposium, I want to thank our sponsor, Ritter Implants, the Canadian Implant Network. Certainly, Mark Bashara did a fantastic job of getting the technology together for us to be able to do this with everybody. And we really look forward with DentalXP and Mark and the and the Canadian Implant Network as well to do this once again. So please, those of you who have participated in this, the viewers, let us know what you think. Let us know what you'd like in the future. Give suggestions in terms of how we can make this better and in terms of topics and speakers that you may want to see. So certainly I applaud all the speakers and I thank you all for participating. It's been a great afternoon for us. Stay safe out there. We'll all get back to normal, hopefully in a short period of time. All the best to everybody.
So thanks, Rick, for joining us today. Thanks to everyone that's joined us this afternoon. We had tremendous speakers from across the globe. And again, this is the first time we've tried something like this. So it's always a good chance to sit down and focus and kind of regain our strength for when we return back to work. So join us again. I'm sure we'll do this again. And thanks again to Henry and Maurice for joining me as well to moderate today.
All the best, everybody. Bye.
Bye, guys.